Dear colleagues, dear friends, it's my great pleasure to welcome you to the Kyiv Summer Stroke Summit 2026. Stroke remains one of the leading causes of death and disability worldwide, with an enormous and still growing burden across Europe. Despite important progress, major disparities in stroke care persist between and within countries. The updated Stroke Action Plan for Europe, published in January 2026, reminds us that achieving meaningful reductions in stroke burden requires coordinated efforts across the entire chain of care, from primary prevention to acute treatment, rehabilitation, and long-term outcomes. Against this background, we are particularly proud to bring together an outstanding, truly international faculty representing Europe, North America, and Australia. This year's summit features a remarkable number of world-class experts and leading voices in stroke, sharing cutting-edge science and practical insights. Over the next 3 days, we will cover the entire chain of modern stroke care. In particular, on day one, we will focus on acute stroke and complex treatment decisions, including new insights into thrombolysis, anticoagulation, and risk stratification, followed by an interactive case-based grand round. On day two, we will address intracerebral hemorrhage, neurosurgical approaches, and challenging vascular pathologies. On day three, will take us from brain health and stroke in the young to frailty, long-term outcomes, and rehabilitation. We are also pleased that for the first time, the summit is fully available in English, opening it to colleagues from across the world, especially from Eastern and Central European countries. Importantly, there is also the first year that the Kyiv Summer Stroke Summit has been accredited for the European CME credits. We believe that this meeting will become an important milestone, contributing not only to professional education, but also to improving the quality of stroke care and reducing the burden of stroke in Ukraine and across Europe. Thank you very much for joining us, and I wish you a very productive and inspiring meeting.
Good morning and welcome to day one of the Kyiv Summer Stroke Summit. It is a great pleasure to have you with us today as we bring together leading experts to advance stroke care across Europe and beyond. We begin our program with a keynote lecture by Professor Francesca Romana Pazzella from Italy, Chair of the Stroke Action Plan for Europe, SAP-E, and Medical Director of the Stroke Unit at San Camillo Forlanini Hospital in Rome. She is a leading expert in stroke care quality assessment systems. Professor Pazzella will present on the European Stroke Action Plan and the strategic framework shaping stroke care across Europe, a highly relevant topic for setting priorities in prevention, acute care, and long-term outcomes across healthcare systems.
Good morning and welcome to the Kyiv Summer Stroke Summit, Stroke Update 2026. My name is Francesca Romana Pezzella. I am the Chair of the Action Plan for Stroke in Europe and the Secretary General of the Italian Stroke Association. I'm very grateful to Professor Marina Guliaeva, Professor Yuri Flomin, for asking me to welcome you today and for giving me the opportunity to present you a very rich program. The first day, we will concentrate on acute ischemic stroke. We will discuss the latest advances in acute ischemic stroke treatment, best practices in stroke prevention, and case-based clinical decision-making in complex stroke scenarios. On the second day, we will concentrate on intracerebral hemorrhage and neurosurgery in acute stroke, as well as on new frontiers in cerebrovascular diseases. And the third day, lectures will focus on modern approaches to stroke diagnosis and preventions, and also key updates for stroke neurologists. Very practical sessions on ICD-10 versus ICD-11 for stroke neurologists are in the program, as well as the presentation of the new animated NIH training and certification program. I really hope you will enjoy this program as much as I do. Thank you very much and enjoy this Kyiv Stroke Summer School 2026. Good morning. My name is Francesca Romana Pensella, and today I will discuss with you spinal cord infarction. And I will treat it as a true neurovascular emergency. The goal is not to memorize a rare syndrome, but to recognize a pattern, abrupt myelopathy, often painful, with a narrow window to exclude compression, identify vascular causes, and support perfusion. I will now move from anatomy and epidemiology to bedside presentation, MRI, acute management, outcomes, and the long rehabilitation phase, because in spinal stroke, the diagnosis is urgent, but the recovery is often long and incremental. On this slide, I want to frame the entire talk with one practical message. Think of spinal cord infarction whenever you see abrupt non-compressive myelopathy, especially if pain is prominent. These patients are often misread as inflammatory myelitis because spinal stroke is rare and many neurologists see only a few cases. The combination of rapid deficit and a clear sensory or motor syndrome and early sphincter symptoms should prompt urgent MRI and a search for vascular triggers. Even though formal acute treatment evidence is limited, time still matters because delays can miss aortic disease, for example, dissection, hypertension, and early imaging opportunities, which are absolutely critical for our patients. This anatomy explains almost everything that follows clinically. The anterior spinal artery supplies the anterior two-thirds of the cord, corticospinal tracts, spinothalamic tracts, and anterior horn cells. The paired posterior spinal arteries support dorsal columns and part of the posterior horns. Segmental radicular feeders, especially the artery of Adamkiewicz, create regional dependence on collateral inflow. Mid-thoracic and thoracolumbar segments are especially vulnerable when systemic pressure falls or a feeder artery is interrupted. Let's talk now about epidemiology. We know that this condition is rare, very disabling, and often with an abrupt clinical onset. The demographic profile tells us that the mean age of patients with this condition is around their 50s in pooled series, but the range we know is broad and older adults are common in routine practice. Male sex is predominant in pooled published cohort and also in clinical practice. Cervical and thoracic level are represented with similar frequency, and more than half of symptomatic patients reach their neurological nadir within 6 hours. So you see, it's critical to have a very rapid and quick diagnosis. Let's talk now about etiopathogenesis. I usually divide etiologies into a few bedside-friendly groups. First, aortic causes, so dissection, aneurysm, or open and endovascular aortic procedure. Second, systemic low-flow states such as shock, cardiac arrest, profound hypertension, or major blood loss. Third, occlusive mechanisms such as embolism, thrombosis, or dissection of a supplying artery. And fourth, and in the fourth, of course, we have the more rare or debated mechanism, like, for example, vasculitis, hypercoagulable states, decompression sickness, and other very rare condition. The practical teaching pearl here is that sudden paraplegia with severe chest or tearing back pain is not just a neurology problem, it could be an aortic emergency until proven otherwise. So it is very important in this phase to carry on a very thorough and complete imaging of the aortic arch and of the aortic vase as a whole. In this slide shifts from etiology labels to pathophysiologic pathway. Different triggers converge on the same endpoint: inadequate perfusion of a vascular territory, which is of course the cause of spinal cord infarction. In some patients, the problem is pure low flow. In others, is an occlusive event, or a failure of a collateral circulation. That is why the same syndrome can arise after aortic cross-clamping, after profound hypotension, or in spontaneous vascular disease. I emphasize this because treatment is mechanism-driven in this condition. There is no single disease-modifying therapy for spinal infarction, so the more quickly we identify the hemodynamic or the vascular mechanism, the more rational our acute management can be. Let's talk now about the clinical pictures and what is the onset pattern and the red flags we have to keep in mind. At bedside, I would like you to remember that the time is the importance of time and the importance of pain. Spinal cord infarction is often hyperacute or very rapidly progressive, and pain at onset is very common. Neck, intrascapular, back or chest pain depending on the level and on the cause. Thoracic lesions usually present with paraparesis, whereas cervical lesions can cause tetraparesis and, importantly, respiratory vulnerability, so patients may develop an acute respiratory syndrome. A distinct sensory level and early bladder dysfunction are common in most cases. Dissociated sensory loss can be a useful clue to anterior spinal artery involvement, but absence of this should not reassure us and should not let us think that, okay, it's not spinal cord infarction, it is something else. It is also very important that we learn to recognize the vascular syndrome patterns. These vascular syndromes are very helpful and are not as, and even though here are presented into boxes, they are not rigid distinctions. And so you should remember that there could be an overlap in the clinical characteristics. In anterior spinal artery syndrome, which is the one that most people recognize, is probably one of the commonest, prominent motor weakness, loss of pain and temperature, sensory and early autonomic dysfunction are the clinical signs that are often present, with which very often patient presents. Posterior spinal artery infarction is less common and can present with sensory ataxia and impaired proprioception. Partial or Brown-Sequard-like infarcts can be diagnostically difficult to recognize because they mimic demyelinating or compression lesions. Conus and epiconus infarction may look like a peripheral problem at first, with saddle anesthesia, areflexia, and early sphincter failure. So you see, always keep in mind that not a single syndrome is obligatory, but you may have mixed and incomplete presentations, which are actually the most common in this already rare condition. So let's now quickly see what are the potential differential diagnosis and mimics. And it's very important that you keep in mind that what is mandatory is always to exclude compression at first. Clues that favor infarction are abrupt onset to nadir within hours, usually 6 hours, prominent pain at onset, vascular triggers, so aorta, hypertension, procedures, DUI restriction, vertebral body infarct, or vessel pathology, of course, on the MRI. And CSF is often normal or only mildly abnormal in these patients. The major mimics are epidural hematoma, abscess, tumor, severe spondylotic compression, inflammatory myelitis, spinodural arteriovertebral fistula, infectious myelitis or abscess, and metabolic or toxic myelitis. A practical rule to keep in mind is that relapsing symptoms, marked enhancement, florid CSF inflammation, or a subacute course should always make ischemia less likely. So if you see these conditions, if you are able to recognize these signs and symptoms, you should always think, well, ischemia is less likely to be the cause of the neurological deficit here. Let's see now what is the needed diagnostic workup and structured diagnosis clinical pathways. Supportive elements for a more secure diagnosis are, as I said, rapid symptoms onset to nadir, classically within 6-12 hours, an intramedullary T2 lesion in a non-compressive cord at the MRI, diffusion restriction, so DVI restriction, vertebral body infarction, or adjacent arterial dissection or occlusion, also at the angio MRI. No better inflammatory, infectious, compressive, or neoplastic explanation of the condition. So the first thing is the clinical picture, so the clinical clue to orientate us. Second thing is to get fast the imaging, and the standard imaging is for this condition is the MRI of spine with the DVI, with diffusion and ADC sequences. Then search for the source. So do CTA or MRI of the aorta, of the arteries, a full cardiac and vascular workup, and recheck repeat the MRI if the first study is non-diagnostic, but if the suspicion remains high. This is because if the first study is done very quickly and the lesion is small, you may not see it at the very beginning. So repeat the MRI in case the first study is not diagnostic. And then, of course, it's very important to classify whether it's a defined, probable, or possible spinal cord infarction within this very clear and structured diagnostic workup. Let's see what are the MRI essentials. MRI is the cornerstone in the diagnosis of spinal cord infarction, but of course it's very important that you request the proper sequences in order to be sure that any potential sign can be captured with this exam. Sagittal and axial T2 sequences are essential, and whenever the scanner and the protocol allow it, you should always ask to add to the neuroradiologist to add DUI and ADC, because restricted diffusion strongly support the infarction diagnostic hypothesis. At the same time, spinal DUI we know that is technically can be technically tricky, difficult. So a negative DY does not exclude the diagnosis. And that's why, as I said before, in some cases, it may be useful to take into account that you might need to repeat the MRI. Stir and contrast may help, mainly by excluding a differential diagnosis, such as inflammation, infection, trauma, or tumor. And the classic morphology of the spinal cord infarction is longitudinal, pencil-like T2 abnormality with anterior horn involvement on axial images. And this pattern is often described as the all eye sign. So look for the all eye sign. The imaging clues that strengthen the diagnosis, these are very practical because many diagnostic errors happen when the first MRI, as I said, is read as normal. In the very early phase, spinal cord infarction can be radiologically silent or only subtly abnormal. So if you don't really know what to look for, you may not get it. So if the syndrome is abrupt, painful, and non-compressive, even if at the first MRI you don't find the axial all eye sign, please do repeat the imaging and also do the MRI angio or the CTA in order to study the vessels as well. Let's see what we can do for our patients. And so let's now discuss the acute phase therapy. In the first hours, the priorities in the emergency phases are, of course, various. First of all, this is a neurovascular emergency until it's proved otherwise. So stabilize the patient, oxygenation, ventilation, blood pressure, and perfusion. Avoid hypertension as much as possible. Excluding cord compression quickly and actively search for aortic dissection or other arterial dissection is very important, and obtain urgent MRI as we said. So stabilize, exclude compression, identify the mechanism. This is critical because once you have identified the mechanism, you can act on the etiopathogenetic mechanism, and acting on it, you may reduce the impact of the spinal cord infection. So the therapy should be always course-directed. Antithrombotics, reperfusion, vascular ruptures, supportive care. These are the things that normally are done. This is because there is no universally accepted randomized treatment pathway for spinal cord infarction, and the management is individualized and etiopathogenetic mechanism driven. So, as I said, I try to be very honest with you about the evidence. For example, IV thrombolysis. It is exceptional, it's not the routine. There are no clinical trials. There are no clinical trials about thrombolysis in spinal cord infection. So it can be considered on an individualized basis. And the evidence available remains limited to case report, small case series, and observational analysis. Aortic periprocedural rescue. This is common rescue measures that include mean arterial pressure augmentation, correction of anemia, hypoxemia if present, cerebrospinal fluid drainage in selected settings, and of course in selected patients, and urgent, those that, for example, underwent aortic procedures, and urgent vascular repair or revascularization when indicated. So when we know that that is the etiopathogenetic mechanism. Antithrombotics. When we talk about antithrombotics, we know that antiplatelet versus anticoagulation is chosen according to the presumed mechanism. Again, atherothrombotic, cardioembolic, dissection related, of perioperative. These four are the main areas where are the main causes, and of course, whether if it's atherothrombotic, you will use antithrombotics. Like if it's cardioembolic, for example, and there are thrombos, you may decide for anticoagulation and so on. There are no convincing evidence for routine steroids in ischemic scored infarction itself, and the response to steroids should reopen the differential diagnosis if you're using steroids. But always remember that steroids are not a standard therapy for patients with an established diagnosis of spinal cord infarction. There is no indication for that. Supportive acute care is very important, and you also should always keep in mind that there are potential early complications, and these concern respiration and so breathing and autonomic control. And this is important to monitor respiratory effort in high cervical lesions, to watch for hypertensions in desperation, bradyarrhythmia, and temperature dysregulation. Bladder and bowel, of course, if there is a problem at this level, a catheter strategy to avoid retention, and also to see what is the bowel regimen, and early avoidance of over distensions is critical. Of course, if the patient is bedridden, DVT and pressure injury prevention are also critical, and so thromboprophylaxis, if it's appropriated, with repositioning, pressure area care, and nutrition are also very, very important. So the early complication, as I said, could be pain, of course, and spasticity. It's important to treat acute neuropathic pain early to help our patient, to avoid skin, nutrition, and mobilization complications with safe transfer from bed to the chair. So monitoring seating or orthasis if they are needed, skin checks if patients is bedridden, and of course put in place a plan for realistic mobilizations. Early rehabilitation planning is very important again. So it is important here to involve rehabilitation medicine. Speech and swallow assessment is relevant if indicated, and the specialist spinal advice also with if it's the case. What are the outcome? Here we have you see the outcome is highly variable, and this is where we should try to avoid both extremes. We don't want a false reassurance or unnecessary nihilism here. Mortality is not negligible, and you see is around 13% in pooled meta-analysis. And this is important. Is an important data. Months matter. Why? Because neurological gains are often on beyond the hospital discharge. There is a very long time to recover. These patients requires a very long rehabilitation program to gain back their as much as they can, and to improve their neurological deficits. The median admission to follow-up in pooled data, we have very heterogeneous studies, so we know it can go from modified ranking scale 3 to 1, and as you know, modified ranking scale is very much about walking, so this usually mean that you may have a patient that starts with 3 immediately after the onset, and after months of rehabilitation can go back to 1. The typical recovery narrative is that you have an acute phase where the deficits can be dramatic with paraplegia, sensory level, bladder, bowel dysfunction, and you have a rehabilitation phase where the patient slowly gets back motor, gait, bowel, bladder control, and self-care goals should be, of course, decided and shared with the patient. And then you have the rehabilitation phase, you have a long-term phase where many survivors keep improving, but they may have chronic pain. And in this phase, as also in the other phase, the pain management is absolutely crucial, and as well as spasticity and sphincter issues that may persist should be assessed. What are the prognostic factors? What is that matters the most and helps us understanding if the patient will have a good outcome or a less favorable outcome? Favorable signs are incomplete motor deficit at the nadir, so at the onset. Smaller or shorter lesions, of course, this is quite obvious. Early neurological improvement is a very important prognostic factor, as well as spontaneous rather than periprocedural mechanism. If it's a spontaneous mechanism, is more likely to improve than post-surgical, for example, a cause of the damage. And preserved ambulation at discharge from the hospital is also a very good sign, because it means that the patient has already recovered his mobility, and a lot of secondary complications such have pressures, ulcers, and skin issues may be avoided. Unfavorable signals, on the other hand, are severe paraplegia or tetraplegia at presentation, extensive longitudinal involvement of the spinal cord, respiratory compromise, or ICU level instability. This is a very bad sign, and may be an indicator of mortality. Peri-aortic of periprocedural infarction, those are the most difficult to be treated and the less likely to improve. And persistent severe bladder, bowel, and pain syndromes are also unfavorable signals to consider for, of course, as a predictor. But the strongest single predictor is the initial neurological severity. So the less severe is the neurological picture at the onset, the better is going to be the outcome. Please do keep in mind. So long-term therapy, rehabilitation is not an afterthought. So we have to think that the treatment phase in which many patients recover and function and participate is not the only one. Rehabilitation targets may be a long-term rehabilitation targets, and at the beginning they may include gait, balance, transfers, learning wheelchair skills, endurance, activities of daily living, but also you have to plan this for a very long time. And it's also important at this level to have bladder and bowel programs to discuss with the patients also his personal life, as sexual function are often compromised in these patients, and it's important for them also to think in terms of skincare, bone health, their mood, fatigue, chronic pain, as I said, and spasticity management are also important, and this may be a need for this patient for their life. This patient, as I said, benefit from a multidisciplinary model of care, where you have not only rehabilitation, physiokinesis therapy or hydrokinesis therapy, but also you have the psychologist, OT, and also multi-professional approach with different physician, urologist, andrologist, and so on, to help the patient improve. Well, once it has happened, we want to avoid it happening again, and also it's important to have a long-term follow-up, structured long-term follow-up. For a long-term follow-up checklist, I suggest you always keep in mind the walking ability of the patient. If the patient needs orthosis, if the patients need a wheelchair, what is the wheelchair type that is more indicated for that patient, and also to establish the participations, the social life, family life participation goals, and if it's possible to go back to work. Bladder and bowel plan, it's absolutely important to avoid recurrent urinary tract infection or retention, and it's important to establish a retention surveillance. As I said, often during this talk, pain is a constant problem for these patients, so management of neuropathic pains, plan spasticity, assess sleep quality, assess mood, and fatigue is also critical for the quality of life of this patient. Bone health, skin health, sexual health should always be part of the plan in order to avoid osteoporosis, to reduce the bone fracture risk. And it's also important to reassess periodically these patients, and of course try to see if there are complications and manage inflammatory complications, for example, and so on. As I said, in terms of causes, for spinal cord infection caused by aortic dissection, you have to see if this was caused by vascular surgery or it was spontaneous. And of course, here you have to manage the patient together with the vascular surgeon. If it was cardioembolic or thromboembolic, anticoagulation or antiplatelet strategy based on the mechanism is essential, and that's why a thorough workup in that direction, cardiac workup, should be established in the acute phase. For patients with atherothrombosis, it's important not the vascular risk factor control. If there is smoking habit, smoking cessation, also monitor adherence to the suggested therapy, like statin, antiplatelet therapy, and so on. In case of rare cases, like with thrombophilia or vasculitis, it's important to have a second level and third level workup in order to understand what is the mechanism, what was the etiopathogenetic mechanism, and the type of thrombophilia in order to treat it properly. So I'm at my last slide. I hope that till now you heard all you need in order to recognize, make the early diagnosis, make a plan, understanding what was the mechanism that caused the spinal cord infection, use the MRI and the CT properly, and design a personalized diagnostic workup and a therapeutical workup for our patients. So our key messages here are 5 take-home points. First, Think spinal cord infarction in abrupt, painful, non-compressive myelopathy. Exclude compression always with quickly, as early as possible, as quick as possible, and obtain as quick as possible MRI with DVI whenever possible imaging. Early MRI, always remember, can be a false negative. So if there is clinical suspicious is strong and remains strong, please repeat it and insist on repeating it and look for the all sign if clinically the syndrome still looks like an ischemic spinal cord lesion. Acute treatment is mechanism driven, so you have to focus on what is the mechanism for those patients. Perfusion support matters a lot. In terms of what we usually do for acute ischemic stroke, so thrombolysis in these patients is exceptional and it is individualized. So there is no standard therapy with thrombolysis in these patients. It's always, you have to consider it is always exceptional and is not in the guidelines. The initial neurological severity is the clearest prognostic marker. So the worst is the neurological deficit at the beginning. The less favorable is going to be the prognosis. But rehabilitation is important, and rehabilitation gains can continue over time for months, for years, and it's important to make a plan where you view and review your patients in order to adapt and manage the many complications that ranges from pain to bladder dysfunction, sexual dysfunction, avoid bone fractures, and so on. So I hope you enjoyed it. For me, it was a pleasure to be with you today, and I'm looking forward to the next Stroke Summer Summit in 2027. Thank you, and have a nice day.
We now move to plenary session 1, which will focus on the latest advances in acute ischemic stroke treatment. We begin with a lecture by Professor Andrew Demchuk from Canada, professor at the University of Calgary, director of the Calgary Stroke Program, and an expert in thrombolysis and clinical decision-making in stroke, who will discuss decision-making in intravenous thrombolysis and how to balance treatment effect with overall outcomes.
Welcome everyone to the Kyiv Summer Stroke Summit 2026. This is a terrific CME event for all of you that's been going on for a number of years now, led by my colleagues, Dr. Flumman and Marina. This is a very important educational event for you all. It's very evidence-based, and I think will help you navigate the complexities of stroke care and some of the very rapid changes that we're all facing. I'll be giving 2 lectures for this summit over the next 3 days. Slava Ukraina. Welcome everyone. I'm going to give a lecture now on decision-making in IV thrombolysis, balancing treatment outcomes and treatment effects and overall outcomes. These are my responsibilities, conflicts, and disclosures. I have been involved in some thrombolysis related activity with industry, with Boehringer Ingelheim, as well as on some advisory boards for medications that may improve reperfusion. When I talk about TPA decision-making, I think about it in this way, and this is somewhat complex, but an important exercise to quickly go through when you're deciding on whether to give a thrombolytic. This is a drug with a somewhat narrow therapeutic index, with a clear benefit on reperfusion, but a harm on bleeding and other complications. So essentially what I do is I identify features in the patient that are very positive or favorable for treatment, and these are all in blue on the left. And then I balance that off with the presence of any red flags, so to speak, that are in the red on the right. Certainly the presence of at least two of these is usually a deal breaker for treatment. I will sometimes consider therapy if it's otherwise very favorable, if there's a single red flag overall. And then there's areas here in orange that are somewhat more controversial and uncertain with regard to the benefits of thrombolysis. This is important when you think about the disease, because we do ask a lot of physicians around the world to make this decision without the expertise and understanding of stroke at the complexity that we need. And so this is where I think telestroke and AI tools are going to help doctors in these remote areas with these decisions. And so many of you may already be participating in telestroke activities. And if you aren't, you should develop them, as this expertise is critical to manage what is an increasingly complex and rapidly changing field of stroke. So I'll go through a number of patient selection considerations briefly in this talk, and I'm going to really talk about things that generally aren't talked about enough, and emphasize them a bit. I'll start with the time window issue, the early versus late time window. We have very clear evidence favoring intravenous alteplase up to a 4.5 hour time window over multiple randomized clinical trials, with the benefit being much greater early in that time window as compared to approaching the 4.5 hour mark. One of the reasons why this is the case is time is brain, where if we can reperfuse the brain earlier, we know less brain has died, and there's a greater chance of good outcome. But something that's not appreciated nearly enough is the concept of time as clot. And what I mean by that is that TPA's ability to recanalize an artery is much greater if you initiate the therapy very early in the time window. The likely explanation for this is that the clot is more amenable to enzymatic breakdown with alteplase or tenecteplase. And this is because it's just lodged, it's irregular, it has holes in it, it may have flow through it, and over time it compacts and sometimes even grows from stasis and becomes far more difficult to lyse with an enzymatic medical therapy. In terms of the late time window, our best data supportive of the late time window treatment is really from the Wake Up trial, which was an MRI-guided thrombolysis trial in patients with unknown time of onset, typically beyond 4.5 hours since last seen normal, where there was a significant overall benefit, but a slight increase in mortality. They used the so-called diffusion flare mismatch, and patients that had diffusion lesions but no corresponding flare lesion, they were randomized. They excluded patients without diffusion lesions, with extended infarcts, or with marked flare lesions overall, and were able to demonstrate the benefit. One very important analysis in that trial was the measurement of the flare hyperintensity compared to the normal side. And as the flare lesion became more visible, the benefit of thrombolysis in this wake-up late window population disappeared essentially completely with the various 90-day outcomes. So you do need to treat patients where the early ischemic changes visible are at best minimal or barely seen. Once it becomes very obvious, these changes, the benefits of thrombolysis are lost. Perfusion imaging has also been used to extend the time window out to 9 hours, and there's certainly some favorable data from several clinical trials in this regard. The challenge with this data is it's in the area prior to mechanical thrombectomy. So what we don't know is whether this would translate to a population of patients in an era where we have mechanical thrombectomy and a 24-hour time window for that therapy. The late window pool data that's been done more recently, post EVT era, has shown encouraging results for improvement in excellent outcome, but still not insufficient data showing a benefit in good clinical outcome or reduced disability, and also evidence of increased bleeding and potentially increased mortality. So there's really pros and cons for these treatments at this time, and several large randomized clinical trials of tenecteplase in the late time window are currently initiating or planned. So we will have an answer in this late window more definitively in the post-EVT era in the coming 2 or 3 years. One trial that was very encouraging from China, the TRACE-3 trial, was done in thrombectomy ineligible patients, showing a benefit. So again, we really do need to figure out whether tenecteplase in the late window is beneficial in patients who don't receive EVT. So for now, my complex decision-making table favors treatment within 4.5 hours, perhaps some consideration of treatment with a wake-up stroke population or up to 9 hours, but still a deal breaker beyond 9 hours from onset. Another important patient consideration is blood pressure, and what's the best target range pre-thrombolysis for treatment. Certainly, when the blood pressure is very high, that is a concern. Original data from way back during the initial streptokinase trials done in the 90s showed an incremental increase of major bleeding in the brain as the systolic blood pressure was higher. This led to recommendations to keep blood pressure below 185 systolic before treatment. A randomized trial called Truth compared this active blood pressure lowering strategy to another strategy employed in the Netherlands, where they don't lower the pressure and don't give the lytics if they don't fall spontaneously. The no blood pressure lowering strategy did seem to be associated with more outcome, but this is not better outcomes, but this is not a randomized study. So it remains unclear what we should do in terms of blood pressure lowering in the immediate moments preceding thrombolytic treatment. Most of us would continue for now to lower systolic blood pressure to 185 before initiating thrombolysis. We have emerging data now from the INTERACT-4 study done in the ambulance with where blood pressure lowering treatment was initiated within 1 hour of clinical onset, where we saw harm in patients with ischemic stroke, suggesting that we have to be judicious in how we think about blood pressure lowering in the first hour or two of stroke when we're deciding on intravenous thrombolytic therapy. Enchanted was a trial that examined guideline recommended blood pressure lowering that was then continued and maintained below the guideline control of 180 versus a more aggressive intensive group of 140. In the group where blood pressure was lowered more aggressively, there was a reduction in intracranial hemorrhage, but there was no difference in overall clinical outcome, suggesting there may be a benefit in terms of preventing hemorrhage, but a harm on making ischemia worse. So we're looking in our large platform of trials that the University of Calgary and the George Institute are leading. We're planning and considering a trial where we test whether we should in fact be lowering blood pressure to below 180 before treatment versus not, given some of the pros and cons of that approach. A third patient selection consideration is hyperglycemia/severe ischemia. There is an important interaction between high blood glucose and very severe brain ischemia. Hyperglycemia accelerates ischemia through the anaerobic glycolysis that occurs during ischemia, that in the setting of a high substrate of glucose leads to very high lactic acid production and free radicals production and increased oxidative stress overall. When you combine that with portions of the brain where the blood flow is so severely disturbed that the brain dies very, very quickly and the blood-brain barrier begins to leak more intensely. That combination of factors becomes quite problematic. One technique that that's been done to assess very severe ischemia of the brain is the cerebral blood volume map on CT perfusion, which will delineate an area of brain where there's no contrast at all getting in, and the patient has extremely severe ischemia. It's a black hole of flow on the CBV map. This has been reported in multiple studies to be a strong predictor of major hemorrhaging into the infarction with reperfusion. You combine very low CBV with a high blood glucose, and your rates of parenchymal hematoma can approach 90% with intravenous thrombolysis or mechanical thrombectomy. So this is a big concern, underappreciated, but easy to detect prior to treatment decision making. Another consideration is the so-called well-evolved ischemia, the flare-positive lesion that I mentioned previously in the wake-up trial, or the hypodense lesion on CT that's easy to see. These are really, for me, red flags in terms of giving a thrombolytic agent. I showed you this slide earlier that as the flare change becomes more evident, that the benefit in favor of intravenous alteplase is lost. You can identify a similar degree of flare mismatch. The corresponding feature on the non-contrast CT is something what we call severe hypoattenuation. As the brain gets more hypodense, it correlates very nicely with a flare lesion. The way I like to describe this is a hypoattenuation, if you're going to do a CT scan and not an MRI, will be as dark as normal white matter. And I think you can see that evidently here very nicely in this second image from the left, where there's early ischemic changes in the entire left MCA territory. It's getting pretty dark and very similar to normal white matter. When you have this degree of hypoattenuation, your risk of symptomatic hemorrhage is elevated with thrombolysis. When you combine that similar degree of hypoattenuation on the non-contrast CT with elevated blood glucose, you have again a very high probability of serious hemorrhage. Moving on now to extensive ischemia, low aspects, very large core volumes. This is another deal breaker for me. We don't treat patients generally anymore with thrombolysis when the aspect score is in the 0 to 2 range, or when the core volume exceeds 150 mils on CT perfusion. Aspects of 0 to 2 typically have core volumes above 100 mils. Aspects is a tool that's semi-quantitative to examine different areas of the brain. So it's not a perfect test. But when we've looked at aspects in large trials, including the NINS trial, the low aspects group is associated with very large, extensive infarctions and poor outcomes. The 150 mil core threshold is now being clearly demonstrated as the point of no return for reperfusion treatments across multiple studies, including data from Hermes that if you do EVT versus control, and your core volume of infarctions over 150 mils at baseline, you actually create dramatically more midline shift and can lead a patient to a malignant MCA infarction much faster. So we must be much more conservative in the management of our patients with either thrombolytics or EVT when the core volume is over 150 mils, or similarly, the aspect score is in that very low aspects range. A very fast way to determine a very large core without having to do a perfusion is something that we do in Calgary called multi-phase CTA. This can be implemented on every scanner in the world with no sophisticated software required or licensing fees, where you simply move the gantry back through the brain twice more, 8 seconds apart, and see the collaterals filling in over 3 phases, again, 8 seconds apart. Here's an example of a patient with an M1 occlusion who has no collaterals on the first phase of the CTA. It's black, completely black, no collaterals. Here's the second phase, maybe one couple little tiny bits of collateral, but really poor collateral filling. And even in the third phase, again, only a couple of vessels showing up. This is a minimal collateral pattern. This patient's going to have a very large infarction overall. This patient was reperfused very early despite that scan, and all we did was create a malignant MCA infarction and rapid midline shift leading to the patient's death. So this is a very clear division or line in the sand when it comes to thrombolysis decision making, and the group in Barcelona was able to identify that the patients with this poor collaterals on multi-phase CTA is a very strong predictor of a malignant MCA infarction with an odds ratio of 10. Prior antiplatelet therapy is another significant consideration with regard to treatment, and there's some evidence to suggest we need to consider lower doses of alteplase in these patients. This in the Enchanted trial, 0.6 milligram per kilogram alteplase versus 0.9 was tested. The subgroup that were on antiplatelets favored the lower dose overall, and this was statistically significantly interaction, with about 6% better good outcomes and 5% fewer deaths in patients receiving the low dose alteplase if they had been on prior antiplatelets. And in fact, there was 1/3 the symptomatic hemorrhage rates with low dose alteplase if a patient was already on antiplatelet agents. It's quite possible that if you're on antiplatelets when you have your stroke, your clots are different. They're less platelet rich and more amenable to IV thrombolysis at lower doses to achieve good outcomes. We're testing this question specifically in ACT Global currently as we're enrolling patients who are receiving IV thrombolysis with either the standard 0.25 tenecteplase dosing versus 0.18 tenecteplase dosing. Prior DOAC use is another consideration, and we have some pretty interesting observational data from multiple studies now that there is no increased risk of symptomatic hemorrhage with DOAC. And so we are testing this question specifically in ACT Global, as is the DO-IT trial in Switzerland, to ensure that tenecteplase is in fact safe. We're comparing no tenecteplase, low dose tenecteplase, and full dose tenecteplase in DOAC, previously treated DOAC patients. Most of us do feel that if the DOAC was not given, was given more than 12 to 15 hours ago, that it is probably safe in that setting to proceed with thrombolysis. But if the DOAC was given within 12 hours ago, we really need randomized trial data before guidelines will change and we can be comfortable with thrombolytic treatment in that setting. What are the absolute contraindications? Well, there really are a few when it comes to TPA decision making. Recent stroke within 14 days, platelets under 100,000, recent intraspinal or spinal surgery, active GI bleeding, aortic dissection, malignant intracranial neoplasm, severe head trauma history, recent intracranial hemorrhage, or endocarditis would all be contraindications. Any prior history of intracranial hemorrhage is probably an absolute contraindication, but maybe, if it's provoked, perhaps not. Some features that now are being considered as only relative contraindications are prior stroke a month or two ago, or recent major surgery in a compressible site. those would now be considered not contraindications. We also know that in pregnancy and in patients with unruptured aneurysms that intravenous thrombolysis is probably safe. What are ideal candidates for the treatment overall? Well, obviously we talked about time, but really it's the small clot, the MC occlusion, and the residual flow that matters. We know that when clots have a length much more than 1 centimeter, that intravenous therapies and enzymatic treatments are just insufficient to recanalize the artery because they're working at the front end of the clot and gradually diffusing through and just don't have enough time to fully lyse these clots. This is where mechanical thrombectomy becomes critical in the management of these patients because the thrombolytic will not be sufficient to recanalize the artery. We also know that if there's residual flow within the clot or around the clot, as X-ray contrast particles can get in or around the clot, there's more surface area for intravenous thrombolytic to work, and patients have a much greater chance of early recanalization with treatment, as we showed in the JAMA publication of the INTERACT study. We also know that the more distal MCA, the distal M1 and M2 are really the sweet spots for intravenous TPA, where we can see recanalization rates close to 80% at 6 hours, and with residual flow around 60% at 30 minutes. What about tenecteplase in this big picture? Well, it is the new kid on the block. We now have multiple randomized clinical trials of tenecteplase, and we have a statistically significant superiority emerging for excellent outcome with tenecteplase, but a perhaps slightly increased risk of symptomatic intracranial hemorrhage, which was not significant at this point, but trending. We know that tenecteplase may be more beneficial if there's a delay to thrombectomy. We saw more benefit in primary stroke centers that had long transport times to thrombectomy. And we also see that as time goes, the longer you have for lytic-induced reperfusion, the more likely tenecteplase will reperfuse better than alteplase in data from the Australian trials. On the flip side, intravenous tenecteplase is associated with more thrombus movement before treatment, so you may run into circumstances when you give tenecteplase that the clot is moved from the M1 into 3 branches of the M2. This can actually make EVT treatment more difficult, as now the interventionalist has to chase into some of the MEVO branches of the MCA to achieve recanalization. So in summary, management of blood pressure pre and post thrombolysis needs further study. Right now, I would still drop the systolic BP below 180 before treatment. Beware of the hyperglycemia, severe ischemia interaction, as it has a high rate of hemorrhaging with thrombolytic. Beware of the well-evolved ischemia. These patients don't benefit from thrombolysis and also are at increased risk of bleeding. So when the hypodensity on the CT scan is approaching the hypodensity of normal white matter, beware. Very extensive early ischemic changes with a low aspect score or very large core are likely futile and may lead to malignant reperfusion with malignant edema. Prior antiplatelet therapy needs to be tested with lower dose tenecteplase, as was it tested and enchanted with alteplase. The number of absolute contraindications for thrombolysis have fallen. The ideal candidates for IV3 thrombolysis are early in the window, small clot, residual flow, and MC occlusion, with tenecteplase being an improved thrombolytic that you should move to, with better recanalization, with more dwell time, but more clot migration. So I will stop there. I'd like to encourage any of you who want to get advanced training in stroke. We have a very active fellowship training program in Calgary. We've trained 125 stroke fellows in 25 countries over the years. We do have funding for training, so if you're interested in coming to Canada and developing a real stroke expertise, we would be happy to chat with you about that and consider that for you. Thank you very much for your time, and hope you have an excellent stroke summit. Bye now.
next speaker is Professor Pooja Khatri from the United States, Chair of Neurology at Yale School of Medicine and Chief of Neurology at Yale New Haven Hospital. She's an expert in acute ischemic stroke and clinical trials and will present on the management of disabling and non-disabling minor ischemic stroke.
Hello, Kyiv colleagues. It's a pleasure to speak with you all, and I hope you're doing well. Thank you for inviting me to speak today on the acute treatment of disabling and non-disabling minor stroke. So you all know this from seeing patients, but mild strokes, specifically those with NIH stroke scale score 0 to 5, are a significant portion of ischemic stroke. And we know this from multiple population-based data sets, that if you really measure, not just look at patients who come to major academic centers, that roughly a third of patients, or actually 2/3 of patients, have NIH stroke scale scores of 0 to 5. And I'll give you an example, and we'll work through a case to talk about how we take care of those patients and things that we need to study more. So 73-year-old right-handed woman has a history of high blood pressure and diabetes. Her exam shows an NIH stroke scale score of 3. She's got just some slight dysarthria. You have to actually ask her family if she sounds a little off. She's got a little bit of left facial droop, and then she's got a pronator drift in her left non-dominant arm, and otherwise is doing well in terms of distal hand movement and the rest of the NIH stroke scale score exam. The symptoms were witnessed to start 2 hours prior, and her TCT scan looks pretty normal. So we all know that, giving IV thrombolysis is one of the most important things we can do. We know for every 3 patients we treat, we're going to make 1 patient at least 1 level of disability improved. And for every 8 patients we treat, we bring 1 patient back to no disability. It was a pretty exciting time when the field shifted in the early 90s to have this therapy. Now, the important thing that sort of makes things more complicated is that for this particular patient is that most of the major trials that have been done with IV thrombolysis excluded patients with some level of milder symptoms. For NINDS part 1 and 2, it was rapidly improving or minor symptoms. And some of the other trials out there also excluded patients in various forms. And I'll talk about this in a second, like how they operationalize rapidly improving or minor symptoms. When I was a fellow learning to take care of stroke patients, there were several cases that I saw that made me think harder about this group and who was excluded and who wasn't. And these are real cases that happened in my fellowship. One patient had trace weakness on one side of their body. I didn't treat them and they fully recovered. And then I had another patient who I didn't treat, but then got worse after the TPA time window, which is the worst feeling to think that maybe I could have done something about it. And then I remember seeing the patient who had only hemisensory loss that I didn't treat, had a thalamic stroke. And when I saw her in clinic a few months later, she was having difficulty working as a cashier, and her neurocognitive testing showed executive dysfunction. So she was still able to take care of herself and not do all the things that she previously used to do. So she had a modified Rankin of 2. And then the last patient that I'll end with is a patient that I'll always remember. She was an employee at the hospital gift shop, and she was in her late 80s, and she had some trace upper extremity weakness, mostly proximal, and some numbness. And she said, I just really want to be myself. I'll take that TPA. And she bled and she died. And made me really think hard about these cases. So I went in with a bunch of colleagues, and we dug into the NINDS TPA trials, part 1 and part 2. And what we found was that in those pivotal trials, there were no patients with isolated ataxia, dysarthria, facial weakness, sensory symptoms, or those with an NIH stroke scale score of 0 but objective symptoms, such as the tropical ataxia patient. And those exclusions were actually explicitly in the manual of operations. I actually checked this, although I will say a lot of the original NINDS TPA trialists didn't even remember that. But then there were also these patients that were not enrolled that weren't listed as potential explicit exclusions in the manual of operations. And those were patients who had hemimotor deficit, just some drift on one side. We see that all the time. There were only 2 patients with isolated aphasia and 3 patients with isolated homonymous hemianopsia. And I presume that's based on the minor exclusion. So with that in mind, I worked with several colleagues to design the PRISMS trial, and our hypothesis was that alteplase would improve clinical outcome for patients with acute stroke, no matter how mild their deficit was. We had to operationalize who we wanted to enroll, and we spent a lot of time on this. We defined it as an NIH stroke scale score of 0 to 5 and judged by the physician in collaboration with the patient to have symptoms that are not clearly disabling at that time of presentation. So what did we mean by not clearly disabling? We said the patient would not be able to do their basic activities of daily living or return to employment if that was applicable. And we taught the mnemonic BATHE, B for bathing, A for ambulating, T for toilet, H for hygiene, and E for eating. The study was sponsored by and funded by Genentech, and it was a true academic industry partnership, which I'm really grateful for. And these were the types of patients we recommended enrolling, although we always said that you have to consider individual person circumstances. A violin player, a professional violin player especially, who that's their form of employment, even a little bit of trace hand weakness could be clearly disabling for them. So it has to be considered in careful discussion with the patient, with their family. And so, but with that in mind, oftentimes a patient with very mild aphasia would be a typical PRISMS patient. If they were still able to communicate meaningfully. And the thought was many of these patients would actually continue to improve. Isolated facial droop, mild cortical hand weakness, especially if it was non-dominant, mild hemimotor loss, hemisensory loss, mild hemisensory motor loss, and mild hemiataxia, but could still ambulate. We also said that there were patients that we typically thought should not be enrolled in the PRISMS trial. For example, if they had complete hemianopsia, we know that does not recover well. If they had severe aphasia, really severe any symptoms, including neglect or weakness. We randomized patients 1-to-1 with alteplase and then a placebo aspirin versus aspirin with a placebo alteplase. IV study drug was initiated within 3 hours. And then the oral drug, which would be the aspirin or the aspirin placebo, was also encouraged within 3 hours. The primary endpoint was 90-day functional outcome. So we know it's standard secondary prevention to give patients aspirin at or upon admission or after 24 hours of reperfusion therapy. And we know for every 100 patients that we treat within 48 hours, 1 fewer would have a recurrent stroke within the next 2 weeks. So that is why we implemented and there was growing evidence at that time related to the POINT trial being ongoing that perhaps giving antiplatelet therapy sooner could be even better for outcomes, which is why we decided I think might be the first time in an acute trial to actually have the control arm get aspirin. So the study was stopped early and it was basically slow going, getting enrollment going. We had 313 of 948 planned patients. Our funding source had other priorities, and we had to stop, unfortunately. And to our surprise, there was no evidence of TPI benefit. If anything, it went in the wrong direction. So excellent outcome, modified Rankin 0-to-1, meaning able to do everything they used to do, but might detect some symptoms or have no symptoms at all. It was 78.2% in the alteplase arm, and it was 81.5% in the aspirin arm. And you can see here the primary endpoint, again, the adjusted risk difference was minus 1.1%. And something I became interested in is there's a lot of information in that confidence interval. So we calculated the posterior probability of less than 2% to show greater than 6% treatment benefit. using a post hoc Bayesian analysis, kind of taking into account the whole picture of the data we were seeing. We did see the expected symptomatic hemorrhage risk. It's 3.2% in the alteplase group, and there were none in the controls. And you can see the actual bleeds right there. I should note that our definition of symptomatic hemorrhage was any neurological decline, because we figured these are mild strokes and that within 36 hours. So any neurological decline led to a designation of symptomatic hemorrhage. So from there, what do we do in daily practice? Well, even though the study was ended early, we had no evidence of treatment benefit, a clear evidence of some harm. And so it sort of tipped the scale for us as a field, and the American Heart Association guidelines, as well as the European Stroke Guidelines and others, took a stand and said IV alteplase is not recommended for patients with mild non-disabling stroke symptoms. Now, I have to admit, I lost some sleep after PRISMs thinking, gosh, that study ended early. What if that finding was by chance? Sometimes you can get spurious results. But thankfully, the Aramis trial came along from China. And what they did is they randomized patients to alteplase within 4.5 hours or dual antiplatelet therapy. And for dual antiplatelet therapy, they started it early and they continued it out to the usual early time frame. I think it was 14 days. I must have that here somewhere. Yes, and 10 to 14 days, and then guideline-based antiplatelet therapy after that. And why did they use dual antiplatelet therapy? Well, in the meantime, the POINT trial got done, and it showed us, along with the CALIS trial, that when we gave clopidogrel with aspirin, or we gave ticagrelor with aspirin for every 100 patients we treated, compared within 12 to 24 hours compared to those who got aspirin alone, there were too few recurrences within those next 30 days. Most of the effect was within the first couple days, and major hemorrhage was slightly higher, sort of became a wash once you went past that month, which is why we always give just short-term dual antiplatelet therapy. So interestingly, we also learned, and this is very soft data, but I've just recently started incorporating this in my talk, but some colleagues from Penn, Brett Kuchera and colleagues, worked with the POINT trialists and did a post hoc exploratory analysis to examine the effect of treatment on overall disability. And they didn't show statistically significant results, but they showed numerically fewer patients with disability when they were on dual antiplatelet therapy. So the kind of hypothesis is dual antiplatelet therapy might actually reduce the stroke-related disability, not just reduce early recurrence from stroke. So one thing I should note with the Aramis trial is that they didn't have the same definition of non-disabling stroke. They required 1 point or less in single item scores for vision, language, neglect, or single limb weakness, and no score in the consciousness section that was abnormal, and they treated within 4.5 hours. And they too had a treatment effect that went in the direction of favoring dual antiplatelet therapy rather than alteplase. 93.8% modified Rankin 0-1 versus 91.4%. The risk difference favored dual antiplatelet therapy, and that was significant. It was actually a non-inferiority study. And they met their pre-planned non-inferiority margin as well. So they did see increased safety outcomes. They used a higher threshold before they considered a hemorrhage to be symptomatic, but they did see increased safety events, 0.9% versus 0.3%. And when you look at the subgroups, the one subgroup that you wonder a little bit about is the NIH Stroke Scale Score 4 to 5 on admission that seemed to favor alteplase therapy. And we wonder, because of the definition they used for mild non-disabling stroke, perhaps they enrolled more patients that had deficits that were clearly disabling for them, especially when you got to the 4s and 5s. They didn't take an individualized approach either, so we wondered if that might play a role. We tended to enroll very few NIH Stroke Scale Scores 4 to 5s in the PRISMs trial. So at this point, the modified Rankin outcomes numerically favor antiplatelet therapy in 2 trials. And the question keeps coming up, would a more sensitive endpoint have favored thrombolysis? And I think I've thought about that a lot, and I just can't think of how that would be when the crude endpoint is going in the wrong direction. So, if it was going in the wrong direction, just one trial, it could have been random, but it's 2 trials, and I'm about to tell you about a 3rd trial where it went in the wrong direction. So you have to think that even if you had a more sensitive endpoint, you're not going to change qualitatively what the therapy is doing or how the parent therapy is looking. Now, and that leads us to the 3rd trial. One of the questions we had as a field was, what if a patient had an LVO? They're a higher risk group, even though they have a mild non-disabling stroke. What if they have diffusion restricted lesions acutely? What if it was in certain locations that we know are bad? And what if they have any visualized occlusion or perfusion deficits suggesting a distal occlusion? And that 3rd bullet point is the basis for the Tempo 2 trial, which was led by Sheila Coutts from Calgary and done in Europe and the United States. They enrolled patients less than 12 hours with evidence of an intracranial occlusion, even if it was just a focal perfusion abnormality, a 9-stroke scale score 0 to 5, and not planned for standard of care IV thrombolysis or endovascular therapy. And the thought there was that those were probably all going to be patients that were not clearly disabling, although they didn't require that to be explicitly measured or stated in their screening logs. Now, they stopped early at 886 patients for futility. And it turned out that over half their patients got dual antiplatelet therapy in the non-thrombolysis arm, and a quarter got aspirin, and almost a quarter got nothing. So you can see here again, same story, 75% with an excellent outcome in control versus 72% with tenecteplase. I should note they used tenecteplase rather than alteplase. And their primary outcome measure was return to pre-stroke modified Rankin level. So just to be clear on that. But the same story is true when you look at their secondary outcome. Just to clarify, that was the one which was excellent outcome, modified Rankin 0 to 1. They did show evidence of greater recanalization with tenecteplase. And we do know this story. We've seen it before. Just because you open an artery doesn't mean that you make a patient better. They still saw the symptomatic hemorrhage that we expected, and they actually saw more death in the tenecteplase arm, again, reminding us that this is not a harmless therapy. Their symptomatic hemorrhage definition required 2 or more points, so kind of a middle ground between any decline for prisms and a 4-point decline for Aramis. I think what was particularly surprising is even in those with large vessel occlusions, the therapy seemed to favor control in subgroup analysis. That really surprised me, as I think of that as a higher risk group that is more likely to decline over time and might benefit from thrombolysis. So the punchline here was no evidence of benefit in the IV thrombolysis trials to date, 3 of them, to counterbalance the expected harm of IV thrombolysis in patients with mild non-disabling stroke, whether you look at PRISMs, which compared alteplase to aspirin, Aramis, which compared alteplase to dual antiplatelet therapy, or Tempo 2, which compared T and K to standard of care. So at this point, some of the things we've talked about as a field is we need to think about how to standardize this non-disabling definition further. It sometimes it's a little tricky, and we see patients sometimes not being categorized in the preferable ways, and we need some more standardized ways for people who don't think about this day and night to be able to select patients who have not clearly disabling deficits. And then the other thing is, you can imagine in the future we're going to have more effective thrombolytics where they're safe and that basically gets your artery open without causing bleeding. So that's sort of the hope for the future. There are several novel lytics, to digress for a moment, in ongoing phase 2 trials that I'm excited about. A few examples are TS23, which is this monoclonal antibody that releases the brakes on just our endogenous TPA rather than flooding our bodies with exogenous TPA. There's DNase, which cleaves the scaffolding of the thrombus, which is composed of extracellular DNA produced by neutrophils. And then there's von Willebrand factor aptamer, which inhibits platelet adhesion. It's probably going to be a combination of these, but you could even imagine someday not needing endovascular therapy, which would be great for rapid reperfusion, particularly in rural areas. Back to our patient then. So our patient she's the one with an NIH stroke skill score of 3, slight dysarthria, slight droop, slight pronator drift. 2 hours out, turns out her left middle cerebral artery is occluded on CTA. So what do you do with her now? Well, we know that endovascular therapy was an incredible win for us as a field in 2015 with 5 landslide trials showing us that for every 3 patients we treated, we improved patients by 1 level of disability, or for every 6 patients we treated, we brought 1 patient back to no disability. However, in thrombectomy trials, we excluded patients in most of them if they had an NIH stroke skill score of less than 6. So the 2 that did allow them were Mr. Clean and Extend IA. And now it's time for my pop quiz. How many of the greater than 2,000 participants enrolled in pivotal trials of endovascular therapy, the ones that were less than 6 hours or 6 to 24 hours, like Dawn and Diffuse 3, had an NIH stroke skill score of 0 to 5? I'll let you think about that for a sec. So the answer is only 14. So not much you can do, you can answer any questions with. So we have, and yet that there are some patients that are going to decline even though they look relatively well. Whether they have disabling or non-disabling deficits is sort of besides the point, because even if they have disabling deficits, the question is the risk of thrombectomy worth it when you consider that they have a relatively low NIH stroke scale score? And a lot of times they have other things going wrong with them, including underlying ICAD, which makes endovascular therapy more risky. Yet we know that about 1/3 of these patients will decline in those first few hours if you do nothing. There's a really nice study done by Centers and colleagues where, using great methodology, they created the ND score, which predicts the possibility of early neurological deterioration. And it's sort of as you'd expect, 3 to 4. If you get 3 to 4 points, there's about 1/3 of those patients are going to decline. How do you get 3 to 4 points? You have a very long thrombus with maybe an M1, or you have an ICAT occlusion. So it's those bigger LVOs. So something to keep in mind when you're thinking about your patients. We tend to admit these patients to endovascular ready hospitals so that we can keep them on endovascular therapy watch in case they decline. I mentioned about the complication issues. Bottom line, the way I think about it is, if you have a low NIH stroke skill score, you must have good collaterals. Why have you developed really good collaterals? It might be you acutely had them, but sometimes it's because you have intracranial stenosis underlying the collaterals. And in that case, there can be technical challenges where you disrupt the wall, like with a stent retriever, you inflame the plaque, you get reocclusion. That can happen even with contact aspiration. And then I'll also mention that, thrombolysis might have the upper hand over endovascular therapy here in theory, although we haven't seen it yet in practice. And that's because better collaterals usually means better IV thrombolysis recanalization. So that's another thing that kind of creates equipoise about what to do with these patients: IV thrombolysis or endovascular therapy or nothing. So the non-randomized data at this point are just a complete wash. And the bottom line is we don't have evidence to support endovascular therapy for unselected patients with LVOs presenting with minor symptoms. You can see that here the effect crosses 1, maybe favors intervention. But that's where we are. So right now, our guidelines, both the American Heart as well as the European Stroke, say that the benefits are uncertain and we should enroll these patients in randomized trials. So what about if there's no trial available? The things that I think about is if their blood pressure is really high, like they're basically essentially compensating for the fact that they need more blood flow. I might consider their CT perfusion data, how much of territory is at risk. The nature of the deficits might play into my thinking, how easy and accessible their endovascular therapy could be, and how sick they are otherwise might play into my decisions. But generally, I am enrolling these patients in trials. I am not consistently treating these patients. And I would say that's true for many of us. Most of us are enrolling in extremis, which is occurring in Europe, particularly France. I didn't get to get an update on their numbers, but they had 729 enrolled of the 824 planned back in October. So they must be getting really close. And then a trial that I helped lead is the Endo-Low trial, which actually ended early and got wrapped into the STEP platform. So basically, we enrolled 143 patients in Endo-Low, and those are being considered part of the STEP trial. It was blinded participant data, so I didn't get to see those results. And now we have 32 patients enrolled in STEP to total 175 as of this month. So I have a few take-home messages here then. So you've got a patient with a clearly disabling deficit. You generally want to treat them with IV thrombolysis, regardless of what their NIH stroke skill score is. And that's a clearly disabling deficit for them. This should be a very thoughtful discussion with the patient and their family. If they also have a large vessel occlusion, you might want to, in addition to giving them IV thrombolysis, randomize them to whether they should get endovascular therapy or not. And then if they have not clearly disabling deficits, I generally wouldn't treat those patients with IV therapy. I would consider dual antiplatelet therapy. And I would again randomize these patients into an endovascular therapy trial. So with that, I will end and thank the trial teams that have shared slides with me and collaborated over the years, as well as my new home, my Yale Youth Stroke team, as well as my very many years home, the University of Cincinnati Stroke team. And I want to send you all the very best wishes for now and for the future. Thank you very much.
The next lecture is by Dr. Ling-Sin Lee from the United Kingdom, Senior Research Fellow at the University of Oxford and an expert in stroke mechanisms and prevention, who will focus on embolic stroke without atrial fibrillation and possible alternative etiologies.
Thank you very much for the invitation and for the opportunity. I hope you've been enjoying the Summer Stroke Summit. My name is Ling-Sin Lee, and I am a clinical research fellow at the Wolfson Center for Prevention of Stroke and Dementia in Oxford. I'm going to tell you a little bit about one of my favorite topics today, which is on embolic stroke without atrial fibrillation. So I hope in the next 20 minutes or so, we'll look at how we should manage these patients, what are the alternative etiologies, and how should we treat them. I'll start with a clinical case, which you probably can think about a very similar one as well. So this is a 44-year-old lady. She has not really any vascular risk factors apart from a known history of treated hypertension. She presented with right-sided weakness and aphasia with an acute NIH stroke scale of 12, so a typical, really acute stroke presentation. Her MRI confirmed she's had a left MCA cortical infarct. She subsequently also had intracranial and extracranial vascular imaging, which showed she did not have any stenosis in the symptomatic territory, which is over 50%. She also underwent cardiac investigations, including a 5-day prolonged cardiac monitoring and transthoracic echo, neither of which found any cardiac source. So the two questions we are going to address are, first, should we treat her with anticoagulation, given that the assumption most likely here is that she's had an embolic event? Or should we be looking for other etiologies? And if so, what are the other etiologies we should be thinking about? So we'll start with the first question. Should we just treat her routinely with anticoagulation, assuming this must be embolic? Now, the case I've just described fulfills the definition for ESAS, which I'm sure you're already very familiar with. So ESAS are embolic stroke without any known causes. So it's really a subset of what we call cryptogenic stroke. So ESAS are cryptogenic stroke where we did not find an etiology despite diagnostic workup completed. Now, what is a complete diagnostic workup will differ by settings. Usually, it means the patient would need to have had a brain imaging to confirm that they've not had a lacunar infarct. They would need to have had intracranial and vascular imaging and extracranial vascular imaging to make sure they haven't got symptomatic significant stenosis. They would need to have an ECG and also at least a 24-hour Holter to make sure they haven't got atrial fibrillation, and standard blood tests to rule out other potential systemic causes. So this patient really fulfills the setup of ESAS. We know from the recent ESO guideline that for patients with ESAS, we suggest the use of antiplatelet therapy rather than anticoagulation to reduce the risk of recurrent stroke. Now, why did we make this recommendation? We've already had 4 large trials for this population where we compared different types of anticoagulation versus antiplatelet treatment, and all of the 4 trials were actually neutral. In this very recent study-level meta-analysis, the investigators pulled all of these trials together, and they found that when you put all of these trials together, there was also similar rates of recurrent ischemic stroke in those treated with anticoagulation versus those treated with antiplatelet treatment. Those treated with anticoagulation, however, had a higher risk of bleeding. What is also interesting is that they also showed that anticoagulation was not beneficial to any subgroups that they looked at. So when they looked at different age groups, men versus women, or based on a selection of people with atrial cardiopathy status. So really at the moment, there is no evidence to suggest that we should routinely treat these patients with anticoagulation. But of course, the story doesn't end there. We currently have an ongoing trial, which is the MOSIS trial, which is hoping to see if we can use a biomarker in this particular setting, mid-regional pro-AMP, to see if this biomarker can help us to select a subgroup of this ESAS population to see if they might actually benefit from anticoagulation. So, as I said, the story is continuing and we'll wait for the MOSIS trial study results to tell us. But in the meantime, of course, we need to be thinking about looking for other etiologies. Now, before we move on to look at what the other etiologies we should be thinking about, I just wanted to plug a small note here. When we talk about complete diagnostic workup, we talked about prolonged cardiac monitoring. In this particular case, the patient had an R test that they had for about 5 days. It's quite common practice in most of the settings that patients undergo a 5-day or 7-day or 14-day prolonged cardiac monitoring. Obviously, in some practices nowadays, they can also go for implant loop recorder. So the question is this enough? Actually, before we consider these being embolic stroke without AF, have we actually done enough to rule out atrial fibrillation? Now, what I'm showing you on the top is a recent systematic review that we did, where we stratified the studies by the duration of prolonged cardiac monitoring. So 1 day, 2 to 4 days, 5 to 7 days, 8 to 30 days, or more than 30 days. And this is not a surprise. The longer you look for it, the more you are going to see. But this is at the study level. So these studies, so those that did 1 day versus those that did more than 30 days, have very different patient population. In the figure at the bottom is this very nice study that was done a few years back now, where they just looked at the patient level. If we do a continuous ECG for up to 4 weeks, where do we pick up the potential atrial fibrillation? And what they showed very nicely, as you can see, is it's really quite front-loading. So most of these AF episodes were really picked up in the first 5 or 7 days. So I think this is suggesting that in most of the care settings, probably doing a 5-day or 7-day R test is sufficient to rule out atrial fibrillation. And this is what the current ESO guideline recommends as well. Of course, in some patients where there's high suspicion that they may have atrial fibrillation, we may consider in those settings doing an implantable loop recorder. Although for implantable loop recorder, I wouldn't have time to go into the details of that, we still need to understand better what those short runs that we see on these implantables mean. They probably are going to be very different from the traditional atrial fibrillation that we see on ECG or on these R tests. So there's still more to learn about how what these tests mean to us. Now, we have done all of the tests we think we should be doing, and we need to think about the other common etiologies. Obviously, with the etiologies, there are other rare things that we're not going to particularly talk about. So we'll be looking at more common etiologies that probably will change how we manage the patients. If I flip the question around, what we're really asking is what are the other investigations we should do? Before we do that, I also wanted to draw your attention to a couple of scenarios to answer really, is there anything that we might have missed on the investigations we already have? Because sometimes we tend to think, okay, we need to do more investigations, but actually there are things that we've already done that probably have already told us what the potential etiology is, but we just didn't pay attention to it. So there are a few things I want to just draw your attention to. The first thing I want to draw your attention to is carotid web. This is actually increasingly being recognized, and it's something that a lot of the groups are very interested in looking at the moment. This condition, carotid web, actually was first described many years ago already, back in the 1960s. What is it? So it is this shelf-like linear filling defect in the posterior internal carotid artery bulb, as depicted with where the arrow is. It is non-atherosclerotic, so it's not associated with atherosclerosis. It usually does not cause any significant narrowing in the vessel. So if you look at significant stenosis, you're not going to actually pick these things up, but they are actually very high risk. As you can imagine, at the back of these filling defects, there's a lot of turbulence forming, and it's really very high embolic risk as a result. Some studies suggest about 10% of young patients with otherwise cryptogenic stroke could have symptomatic carotid web. So this is actually not even rare, but it's a condition where if you don't know, if you don't look for it, you are most likely going to miss it. It's more frequent in women and also in those with African descent. It carries a very high risk of recurrent stroke on medical therapy, and that's one of the reasons we began to look for these in our centers. We had patients where we put them on antiplatelet treatment, and they were young without any vascular risk factors, and they kept coming back having recurrent events in the same territory, and eventually we realized actually they had carotid web. The figure on your right basically shows a study published in JAMA Neurology back in 2021 looking at recurrent stroke and recurrent ipsilateral ischemic stroke in patients with carotid web versus in those without. As you can see, patients with carotid web really have a much higher risk of recurrent stroke. So this is a condition that we really need to get more familiar with, and then probably can ultimately change our management. As I said earlier, it's quite easily missed, particularly on ultrasound scans. It is perhaps best seen on CTA or DSA with an oblique view, which is shown as the picture on your right. If you know what you're looking for, the black thing there is actually quite easy to see. So if you know what you're looking for, you will less likely to miss it. If we do find a carotid web that is in the symptomatic territory, then the ESVS guideline 2020 recommends that we probably should be considering carotid endarterectomy or stenting. We've been doing carotid endarterectomy for a couple of our patients with this condition in the last couple of years, and they all did very well, and they all presented with recurrent events, but after the carotid endarterectomy, no recurrent events so far in our case series. So really, this is a condition we need to be thinking about because it actually does alter what we do with these patients. Another etiology or scenario that I want to mention to you is non-stenosing plaques. Again, for many years, all we will be looking for etiology-wise are symptomatic significant stenosis. But non-stenosing plaques or mild carotid stenosis, for example, are very common. And in recent years, we begin to realize that these are perhaps causally related to these cryptogenic strokes. There are some observations that support this potential hypothesis. First of all, researchers have showed that this mild carotid stenosis is more common on the ipsilateral side of the ESAS events compared to the contralateral side. So it's more likely to be on the symptomatic side. Also, these mild carotid stenosis in patients with ESAS also tend to have high prevalence of high-risk features. I'll show you what these high-risk features later, but essentially these are things like soft plaques, plaques with ulceration, or intraplaque hemorrhage. So these are high-risk features that we know are likely to cause symptomatic events. Thirdly, we also saw that plaques with these high-risk features are 5 times more prevalent in the ipsilateral compared with the contralateral side of the stroke. So it's not just mild stenosis is more common on the ipsilateral side, but also these high-risk plaques are also more prevalent in the ipsilateral side compared to the contralateral side in patients with ESAS. What is even more interesting is this study where they followed up all of these patients and they checked whether they developed atrial fibrillation 10 years down the line. What they showed was that AF was also less frequently detected in patients with ESAS and ipsilateral non-stenotic carotid plaques, suggesting that in these patients, really, the carotid plaques, although non-stenotic, probably are causally related. Again, it has potential implications in terms of treatment. Maybe for these patients, we will need to have more stringent criteria for lipid control, and then they might benefit from other more stringent management of atherosclerosis more generally. So this is the system I was talking about, looking at different elements of high-risk plaque features. This is called the plaque REDS, which is a score that was developed. So if you're interested in how you can actually look for these high-risk features, I highly recommend that you read this paper. This score can be used using different imaging modalities as well, so MRA, TCD, ultrasound scan, CTA, or DSA. So it's actually quite a useful tool. Right. Moving away from the vessels, one of the things I'm sure lots of you are already aware of, but I also want to remind people is that in the ESAS setup, the diagnostic workup that's required is a transthoracic echo. However, a transthoracic echo without a bubble study is not sufficient to rule out a PFO, which is an etiology we should be thinking about. So bubble studies are required. Transcranial Doppler, as you might know, probably has the best sensitivity, but in many other healthcare settings, transthoracic echo or transesophageal echo with bubble studies are used for screening of PFO. Very quickly, why do we screen for PFO? We have now the ROPE score and the Pascal classification system to help us to decide whether these PFOs are causally related to the stroke. Basically, in the Pascal classification system, they've taken into account the ROPE score, but also the PFO features. So whether this is a large shunt, whether it has atrial septal aneurysm, and then based on the combination of the two, you get a likelihood of this event being PFO related. And we know in patients with possible or probable PFO related stroke, according to the Pascal classification, PFO closure is recommended in addition to antiplatelet therapy under the age of 60. And in people where we think the PFO is unrelated, then PFO closure is unlikely to be beneficial. So that's the reason why we're screening for PFO at younger ages and what we would then do. Now, there are two interesting questions with regards to this. So the first is, obviously, the current guidelines says we should really be doing this under the age of 60 years old, and we should really be closing PFOs under the age of 60 years. But is PFO really only relevant at age less than 60 years? Because we've got lots of patients with otherwise cryptogenic stroke over the age of 60 years. We did some work around this a few years ago. What we found was that the association between PFO and stroke or cryptogenic stroke is actually even stronger at older ages compared to at younger ages. And this is for PFO of any size or PFO of large size. As you can imagine, these patients are going to be treated with antithrombotics at the moment. And if we plot the risk of recurrence on antithrombotic treatment in patients with PFO and cryptogenic stroke by age, this is, again, not a surprise. The risk increases by about 50% for every 10 years of age. And for those at age 60 years or more, the rate of recurrent ischemic stroke is about 3.3%. So it's not negligible. So these are people we probably need to do better to prevent them from having another event. Moreover, it's not that the absolute risk is higher, but also it's higher compared to patients without a PFO. So again, it just highlights that we probably need to think about other things that we might be able to reduce this risk of recurrence. PFO closure obviously is an obvious next step to think about. There is currently a trial which is running in France, the CLOSE2 trial. So they are comparing PFO closure to different antithrombotic strategies in patients with PFO-associated stroke at older ages. So we should really keep an eye on CLOSE2 and see whether it will give us guidance in terms of whether PFO should be screened at older ages and how we should treat PFO at older ages. There's already some very interesting and encouraging signal. So here I'm showing a recent study from the US where they used routinely collected data. So what they did was they took all patients aged over 60 years who were hospitalized with ischemic stroke and who had PFO or atrial septal defect. And they did propensity score matching so that they ended up having about 1,000 patients in a device group. So these are patients who ended up having a device put in, and they had about 4,000 patients who are in the control group, so who did not have the device put in. About half of these people were women, and the median age was about 71 years, and the median follow-up was about 2.5 years. And they showed very nicely, so in this Kaplan-Meier curve in the middle, so the red line here is people who did not undergo the procedure, and the blue dotted line is people who had the device put in, so who had PFO closure. And this, remember, this is all patients at age 60 years or more. And as you can see, PFO closure with the device significantly reduced risk of recurrent stroke by actually quite a big, almost 40%. And what is reassuring is that if you look at mortality or atrial fibrillation, which is something that we worry a lot for the older patients, it's actually the device group is not that much higher than the control group. Of course, this is observational data, and it's a very selected group that had the device put in. So we will still need to have the trial data to better guide us in terms of what we need to do for these patients, but at least the signal seems to be reassuring. Now, this is a very tiny point I wanted to talk about. When we are doing screening, what we're looking for is really a right to left shunt. And in most of the circumstances, it's going to be a PFO. But is a right to left shunt always a PFO? And the answer is not really. There is also pulmonary AVM that can also have a very similar finding on these bubble studies we do. The difference is that the bubbles come in a bit later. These pulmonary AVMs are usually occurred until the stroke event, so they are asymptomatic from the patient's point of view until they actually had the stroke. It's a persistent shunt, so it actually carries quite a high risk of recurrence. It usually is associated with younger age in people without any risk factors, and they tend to have some silent brain infarction as well. As I said, these are quite high risk features because it's a persistent shunt and quite a big shunt. If we suspect this might be the case, then a thoracic CT is really what we should go for in order to make the diagnosis and decide on the treatment strategies. Again, this is something that is not very common, but it's something that we need to bear in mind when we're looking for etiologies for our patients with embolic stroke without atrial fibrillation and when we see a shunt, but it's not a PFO. Now, we've done the standard investigations and we may not have actually still found the cause. So the next question is, should we be performing more advanced cardiac investigations particularly? Here I'm listing the different cardiac investigations that we commonly use. So we've got transthoracic echo, transesophageal echo, cardiac MRI, and cardiac CT. And I've listed what they are good at picking up. Two things to particularly mention here is that cardiac MRI is particularly good at picking up some of the sort of emerging etiological mechanisms, so atrial cardiomyopathy, silent MI or myocarditis, and cardiomyopathy. So if you are highly suspecting that your patient have got these sort of etiological mechanisms, then I think cardiac MRI would be helpful. Cardiac CT is very similar in terms of their pickup of etiologies compared to transesophageal echo, but it's non-invasive, and they are probably slightly better than picking up non-cardiac etiologies. So if you're looking for example, aortic arch atherosclerosis, then cardiac CT probably will be better. They probably is also able to see left appendage thrombus a bit better. But overall, when you're thinking about whether we should do these things, we need to know the yield, so the pickup rate more generally. And in fact, the pickup rate is really not very high. So it's really 1 to 5% with most of these modalities, especially if we rule out using this to look for PFO, is really probably only 1% that will eventually change our management. Again, I think we are making the decision about whether we should screen for certain etiologies. We just need to be thinking about the yield as well. Of course, if the resources are unlimited, then we could potentially do all of these things more routinely. The other thing that people might be thinking about is whether we should be screening for cancer, and this is a very valid point. There are already quite a few tools that have been developed to help us to decide who we should be thinking about screening for cancer, because again, this is not something we're going to do it to everyone. CALD-5 is a score that was published recently. So the items that the score include are age, ESAS, so the condition we're talking about, multi-territory infarcts, and increased D-dimer, and female sex. And a score of 3 or more has a reasonable sensitivity and specificity. And this is a score that you might want to have a look and see whether it might help you to guide your decision about screening for cancer. Last year, there is also a very nice systematic review that was published in the European Stroke Journal, where they looked at all of the tools, including a CALD-5 that I just told you about. And then they came up with this algorithm, again, to help us to decide what we need to do for cancer screening. Effectively, the things that are most important are D-dimer level and embolic pattern in MRI. And with the combination of these things, if there's high suspicion, then the recommended set of assessments you should do in the first place, and then some more advanced things you should do afterwards. If it is moderate suspicion, they also have some recommendations in terms of what we need to do for specific subgroups. And obviously, if there's no suspicion, then a cold malignancy is very unlikely, then we don't really need to do any other things. So putting this all together, I think D-dimer is something that is actually quite important. If this is something you're not routinely done, maybe you could be thinking about having it done more routinely for your patients as well. There's some studies looking at how D-dimer helps to select patients to go for prolonged cardiac monitoring to increase the chance of picking up atrial fibrillation, for example, and also in studies where they look at the mechanisms in PFO-related stroke. So I think D-dimer overall is a good marker for understanding stroke etiologies. Thrombophilia screening is another area of increasing interest. I recommend this topic review that was published in Stroke a few years ago, and it really talks about who we should be screening for, when, and what we should be screening for. Overall, the general consensus, and I'm just showing you the recommendations from the British Society for Hematological Conditions. And this is the general view that testing for heritable thrombophilia is not recommended in patients with stroke, regardless of age. However, we should be thinking about testing for antiphospholipid antibodies all of the 3 antibodies in young patients without any other identifiable risk factors. One of the things we usually do, I don't know whether this is what you do in your practice as well, is we do thrombophilia screening, including screening for these 3 antibodies at baseline. And if they are high, we do it again at 12 weeks. And if they are persistently high, then our hematology colleagues will then be happy to start anticoagulation. There's a very interesting paper published from the Secreto group last year, which challenges the view a little bit. So what they did was they did screening for these 3 antibodies at baseline and at 12 weeks. And they also screened some controls without stroke. What they found was that in a significant proportion of people where their baseline readings were normal, they actually had quite a significant reading or significantly increased the reading at 12 weeks. So this is suggesting maybe we should actually just be doing these screening at 12 weeks instead of at baseline, given that even when they are high at baseline, we may consider it as being responsive, and then we need to repeat at 12 weeks anyway. And we might miss people who are falsely negative at baseline. Right, so to conclude very briefly about other etiologies that we need to be thinking about, as we talked about, really, we should be first thinking about missed etiologies on existing investigations, such as carotid web and non-stenosing plaques. Further investigations with bubble studies are useful, and we need to be doing that under the age of 60, and we really should be waiting for close to guide us in terms of what we should be doing at older ages. And in certain patients, we can also perform more advanced cardiac imaging, including cardiac MRI and cardiac CT. And for patients where there are risk factors, we should be thinking about cancer screening and thrombophilia screening. So to conclude, the scenario we're talking about, so patients with embolic strokes without atrial fibrillation, is actually quite common. About 1 in 6 patients may present like this. We know from the 4 ESUS trials that routine anticoagulation is not recommended, and we still have other studies that are ongoing to see if using a biomarker will help us to select a subgroup that will eventually benefit from anticoagulation. When we are thinking about looking for etiologies, we should think about treatable etiologies that can be missed on standard diagnostic workup first. And of course, we also have choices of more advanced cardiac investigations, cancer screening, and also thrombophilia screening. One last thing to say is that we tend to do all of these things for patients at younger ages, but on the other hand, we tend to forget about all of these things at older ages. In fact, actually, the pick-up rate of all of these things for cancer screening or cardiac investigations are much higher at older ages. So we just need to remember that for all of the investigations, we also need to think about our patients at older ages. And lastly, I just want to recommend this very nice review that was published in European Heart Journal in 2024, where they really very nicely summarized all the potential etiologies, mechanisms for patients with embolic stroke without atrial fibrillation. And if you're interested, I think it would be a good piece to read. And I thank you very much for your attention. If you have any questions, please feel free to get contact with me as well, and I'll be very happy to answer any questions via email. Thank you, and hope you enjoy the rest of the summit.
This brings us to the end of plenary session 1. We now move to plenary session 2, which will focus on the best practices in stroke prevention. We begin with a lecture by Professor David Waring from the United Kingdom, Professor of Clinical Neurology and Head of the Research Department of Translational Neuroscience and Stroke at the UCL's Queen Square Institute of Neurology, and an expert in anticoagulation and cerebrovascular diseases, who will address early versus late anticoagulation in ischemic stroke patients with atrial fibrillation.
Hello, everybody. It's a great pleasure to be able to contribute to this Kyiv Stroke Summit 2026. My name's David Waring. I'm a professor of neurology at the UCL Queen Square Institute of Neurology in London, UK. And as I said, it's a huge pleasure to support this initiative. I'm going to be talking about anticoagulation in acute ischemic stroke with atrial fibrillation, with reference to randomized trials and individual patient data meta-analyses called Optimas, Catalyst, and Beyond. These are my declarations of interests, and this is the plan of my talk. I will briefly give some background to this common clinical challenge of the timing of anticoagulation in acute ischemic stroke with atrial fibrillation. Then I will talk through the Optimas trial, which was a large UK randomized trial on this topic. I will then go through the Catalyst individual participant data meta-analysis, which includes all of the available randomized controlled evidence on this topic. And then I will give a summary and some recommendations for clinical practice. Okay, so everyone on the line and in the audience will be aware that atrial fibrillation is a common cause of ischemic stroke. Round about 1 in 5 ischemic strokes are related to atrial fibrillation. And this slide shows some of the common neuroimaging patterns. These strokes tend to be more severe than stroke of other mechanisms. So prevention is a key challenge. Now, we know that oral anticoagulants are extremely effective in long-term stroke prevention in people with atrial fibrillation and ischemic stroke. But the large clinical trials that showed this did not include people in the very early stages of acute ischemic stroke. In other words, in the first few weeks after recurrent ischemic stroke, after an acute ischemic stroke. So we have this very common therapeutic dilemma of wanting to initiate anticoagulation early to reduce the early recurrence risk of ischemic stroke from further embolism from atrial fibrillation, and balancing this against the concern that starting oral anticoagulation early may increase the risk of hemorrhagic transformation of the acute infarct, which may have serious consequences and worsen clinical outcomes. So this dilemma has been around for decades, and you will all know that it is something that we have to deal with on every ward round on the stroke unit. And just to bring this dilemma to life, these are some examples of where anticoagulation was delayed on the top panels A and B, where anticoagulation was delayed for about 10 days. And we can see that during that period of delay, this person with a right middle cerebral artery territory infarct had a recurrence, an occlusion of the left middle cerebral artery, proximally causing very severe clinical consequences for that patient. And on the other hand, in panels C, D, and E on the bottom, which you can see here with the pointer, we can see where anticoagulation was initiated early, and we see this hemorrhagic transformation of the infarct, which caused a clinical worsening for the patient. Guidelines in recent years have been inconsistent and have told us that in this setting we should delay anticoagulation for a variety of different periods that you can see here. I won't go through them in detail. And many of you will be familiar with the European Society of Cardiology guideline, the 13612 rule that anticoagulation should be delayed for different periods according to the clinical severity of the acute stroke syndrome. And as we'll see, we've got very little evidence now to support this kind of idea. Okay, so that was the background and the introduction, and now I'm going to talk you through the Optimas trial in the United Kingdom. So the aims of this trial were to determine the efficacy and the safety of early versus delayed oral anticoagulation in a very broad population of people with acute ischemic stroke associated with atrial fibrillation. And we were particularly interested in important subgroups, including people with moderate to severe stroke, in whom we may be more concerned about hemorrhagic transformation, people who've received reperfusion with thrombolysis, mechanical thrombectomy, or both. Again, increased risk of hemorrhagic transformation would be a concern. And finally, people who are already taking an oral anticoagulant at the time of their stroke. And we know this is a high risk group for recurrence. So this was a multi-center phase 4 blinded endpoint randomized controlled trial that we ran at 100 UK hospital acute stroke units. We included people with acute ischemic stroke and atrial fibrillation in whom the treating physician was uncertain about the optimal timing of DOAC initiation. We had no restriction on stroke severity. Hemorrhagic transformation was allowed, apart from PH type 2, which is the most severe bulk hematoma within the infarct, more than 30% of the volume exerting mass effect, with quite a rare type of hemorrhagic transformation. Randomization was online, and the intervention was early DOAC administration at 4 days or less, and the comparator was delayed initiation of a direct oral anticoagulant between day 7 and day 14. Randomization was stratified by stroke severity, and you can see the map there of the sites that we had across the UK. The primary outcome was the recurrent composite of recurrent ischemic stroke, symptomatic intracranial hemorrhage, unclassified stroke, or systemic embolism at 90 days. Participants and treating physicians were not masked, but all outcomes were assessed by an independent external adjudication committee masked to allocation using all available clinical records, imaging reports, source images. We did a modified intention to treat analysis. I won't go through these eligibility criteria in detail. You can read them in the manuscript that the reference is given at the bottom of the slide. So this was a simple one-to-one randomization to early DOAC within 4 days compared to delayed DOAC between day 7 and 14, with follow-up at 90 days for the composite of ischemic stroke, symptomatic intracranial hemorrhage, or systemic embolism. The exact initiation of timing of treatment within those early and delayed time windows was at the discretion of the treating clinician. And our statistical approach was that we initially wanted to know whether early DOAC was at least as good as delayed standard DOAC initiation. So we tested for a non-inferiority margin of 2 percentage points, which based on previous data would suggest that this magnitude of effect would discourage early DOAC initiation. This is the trial flow chart. We had 3,621 people in the modified intention to treat population, and only 3 people were lost to follow-up. These are the characteristics of the population. So we had a mean age of 78.5 years. We had slightly more males than females, and you can see the other characteristics here. I'll draw your attention to the fact that about 35% were already taking an oral anticoagulant. About 30% had some form of revascularization with thrombolysis, endovascular therapy, or both. And nearly 900 people had a moderate to severe stroke with an NIHSS of 11 or more. And remember, these were the groups that we were particularly perhaps concerned about early administration of an anticoagulant. So straight on to the main result. This is our primary outcome. You can see the time to event curve here. And essentially, we see identical rates of the primary outcome in the early compared to the delayed allocation group at 90 days. What you can see, though, is that we have apparently fewer early recurrences in the early DOAC administration group if we look at the 30-day time period. And this was, as you would imagine, this was highly significant for the test of non-inferiority. So we have very strong evidence that early DOAC initiation is at least as good as delayed DOAC initiation. If we look at perhaps one of the most important safety concerns on the right panel here, we can see no statistically significant increase in symptomatic intracranial hemorrhage. And we can also see here the ischemic stroke curve on the left, again showing this possible reduction in early events, but no difference over a 90-day time period. And then if we look at these important subgroups that we're interested in with regard to stroke clinical severity, with regard to reperfusion treatment, and with regard to previous anticoagulation, we see no heterogeneity in the effect, and we see no modification of the overall effect of DOAC initiation based on any of these characteristics. So there doesn't seem to be any concern about the primary outcome or indeed the risk of intracranial hemorrhage for any of these subgroups, which is very reassuring. And this is just to show the range of people that were included in the study, to show that we have people with large territorial infarcts in both the anterior and the posterior circulation. So I think we can conclude from Optimas that in this very broad population of people likely to be representative of the overall population of acute stroke with atrial fibrillation, early DOAC initiation was non-inferior to delayed initiation for our composite primary outcome of recurrent stroke or systemic embolism. Early DOAC initiation is safe with a low rate of symptomatic intracranial hemorrhage, and these findings do not support the previously supported practice of delaying DOAC initiation, regardless of stroke severity, reperfusion therapy, or prior anticoagulation. And the next project that we wanted to do after Optimas was an individual participant meta-analysis called Catalyst of all of the available randomized data on this topic. This is now what I'm going to talk about for the remainder of this short talk. So Catalyst was an individual participant data meta-analysis of all of the available randomized controlled trials on this topic of timing of direct oral anticoagulant administration in the context of acute ischemic stroke with atrial fibrillation. The reason for doing this was, of course, that although we had some data from these separate randomized controlled trials, there remained uncertainty, particularly about efficacy of early direct oral anticoagulation. In other words, was this strategy associated with a lower risk of early stroke recurrence, which would be the aim of starting anticoagulant early in this setting? And we hope to resolve this uncertainty by including a larger population, increasing event rates, allowing greater statistical precision to estimate event rates. We wanted to know whether early start was superior to later start of DOAC, particularly for the recurrence of ischemic stroke, and to confirm the safety of early DOAC administration. Once again, we wanted to explore these effects in pre-specified subgroups, and as I said, confirm the safety with intracranial hemorrhage as our major concern. So we included people from these pre-registered randomized controlled trials called Timing, which was from a Swedish stroke registry study. ELAN was a global trial led from Bern in Switzerland, but with an international participation. Optimas we've covered, and START was an American trial, a smaller trial led by Steve Warwick in Texas. So we had to harmonize the data in terms of the timing of DOAC administration to allow us to preserve randomization among the trials. So we defined early DOAC initiation as within 4 days and later as within 5 days or more. This allowed us to include people from the ELAN study with moderate stroke, but it did not allow us to include all of the people from that randomized trial. But you can see here the numbers of people from each of the trials that we were able to include. And our primary outcome was at 30 days and a composite of recurrent ischemic stroke, symptomatic intracerebral hemorrhage, or unclassified stroke. So we pre-registered the analysis, and you can see here some detail about data sharing and data collection. This was a one-stage IPDMA using a generalized linear mixed effects model. We analyzed according to intention to principle, and we looked at the subgroups of stroke severity, reperfusion treatment, previous anticoagulation, sex, and age. And we also looked at the secondary outcomes of individual primary outcome components. We included 5,411 participants in this IPDMA, and you can see the numbers there from each trial. These were the baseline data with a mean age of around 78. And you can see here the number of people with various stroke severity, those who had reperfusion therapy, around 33% overall. And you can see the other characteristics there on the slide. Going straight to the result, the primary outcome, we found that there was a reduction in the primary outcome from about 3% in the later DOAC administration group to about 2% in the early DOAC group, a 1% absolute reduction in recurrent stroke, with an odds ratio of 0.7 and a p-value of 0.04. If we look at those key subgroups, we see no heterogeneity for the subgroups of concern, including severe stroke, including reperfusion therapy, and including prior anticoagulation. If we look there at the breakdown, we can see that there was no increase in the risk of symptomatic intracerebral hemorrhage. You can see the very low rates here for early and later DOAC administration. So this was once again very reassuring. And then we have some secondary outcomes at 30 days, and we have the further outcomes here at that time point. And the interpretation of this result is that we have a 1% absolute reduction in the primary outcome favoring early direct oral anticoagulant administration, giving us a number to treat for preventing a stroke within 30 days of 108, which is of comparable magnitude to the effect for aspirin in acute ischemic stroke in preventing stroke within the first 30 days, which is 140 from this systematic review. You can read the paper and the editorial in a bit more detail in the Lancet. The reference is given here from July 2025. This slide just summarizes those clinical trials that were included. There are some remaining uncertainties, particularly the impact of infarct volume. The ELAN trial looked at this, and in brief, you can see there's a categorization into minor, moderate, and major in terms of infarct size. And we see there's a signal of possibly even greater benefit in those with larger infarcts, but with very wide confidence intervals and some imprecision around those estimates. We've also looked at this in Optimas, where we measured the infarct volume precisely using a variety of manual and automated segmentation techniques on CT and MRI. And what we see is that there appears to be no concern with regard to the primary outcome or the rate of intracranial hemorrhage in people who are given a DOAC early with larger volume infarcts. And you can see the curves here for early versus delayed anticoagulation, and even with some suggestion that there may be a greater benefit in those with larger infarcts. We've still got some uncertainty about hemorrhagic transformation. The types are shown here. And a preliminary analysis from the ELAN trial once again suggests no major concern of hemorrhagic transformation, apart from a possible adverse effect of severe parenchymal hematoma or remote parenchymal hematoma. This is data from the Optimas trial, unpublished data showing this. Again, no obvious concern with hemorrhagic transformation of the infarct, but with wide confidence intervals. So I'm going to sum up by saying that the data that I've presented suggests that certainly in carefully selected milder patients with acute ischemic stroke, early oral anticoagulation is low risk and reasonable. This is now from the 2026 guideline. And the guideline tells us that the efficacy is not established, but note that that did not yet include the data from the Catalyst collaboration. So I imagine future guidelines will include that, and there will be evidence of early recurrence prevention. So in summary, most patients with acute ischemic stroke and atrial fibrillation, it's reasonable to start direct oral anticoagulant within 4 days. This includes people with intravenous thrombolysis and thrombectomy. It may be reasonable to delay slightly longer for those with very large infarcts due to the limited data available. Similarly, for those with very severe hemorrhagic transformation. We need further data on timing within those first 4 days, and we have some more analyses from Catalyst that will be presented at the European Stroke Organization conference in Maastricht in May 2026. I'm going to stop there, and thank you very much indeed for your attention to my talk.
The next lecture is by Professor Anish Singhal from the United States, Director of the Comprehensive Stroke Center at Massachusetts General Hospital, Associate Professor of Neurology at Harvard Medical School, and an expert in stroke in young adults and rare cerebrovascular disorders, who will present on non-atherosclerotic cerebral arteriopathies.
Well, it's so lovely to be participating in the Kyiv Summer Stroke Summit 2026 in May 2026. My name is Anish Singhal. I'm visiting you from Boston, Massachusetts. It is a real pleasure to be in this summit. I was delighted to accept the invitation by Professor Yuri Floman. I see from your agenda that you have wonderful speakers from around the world, and I hope you will enjoy. At Mass General, I direct the New England Regional Coordinating Center for the NIH StrokeNet, so we do clinical trials for stroke. I also direct the Mass General Hospital Comprehensive Stroke Center. I have teaching appointments at Harvard Medical School, and my long-standing interest is on the topic of cerebral arteriopathies. I don't have any relevant disclosures other than writing chapters for things like UpToDate. Today, I will try to illustrate the key clinical imaging features, acknowledge challenges, and propose an approach to diagnose an arteriopathy, and then a few points about managing specific cerebral arteriopathies. So if you think about it, arteries supply the brain, and it is the problem of the arteries that accounts for the majority of the strokes. This includes atherosclerosis and non-atherosclerotic arteriopathies and small vessel disease like lipohyalinosis. The younger you are in age, the more common it is for an arteriopathy to cause a stroke. Today's talk, I will only focus on non-atherosclerotic arteriopathies, which by nature are seen more commonly in younger adults. What is an arteriopathy? Well, we can list and classify them in many ways, based on mechanism, based on etiology, and so on. I like the approach of whether the angiogram reveals an arteriopathy or not. So angiopositive and angionegative arteriopathies. The first category, you can get it from infections, the most common being carotid artery dissection, a syndrome that I've described called RCVS and PRESS, and a variety of other causes as listed on this slide. These generally cause arteriopathy with angiopositive. Predominantly small arteries where the angiogram resolution is not adequate to pick it up includes mainly primary angiitis of the CNS and cerebral amyloid angiopathy-related inflammation, and also genetic arteriopathies like CADASIL, CAROSIL, COL4A1, and others. There is, of course, overlap. For example, you can see a syphilitic arteriopathy with a normal angiogram. So this is not a hard and fast rule. These are just more common. Notice here that primary angiitis, the most common angiographic feature is no abnormality, but many patients with PACNS can have angiographic abnormalities. So the large ones, we can detect and suspect them right away. The small vessel arteriopathies are much more challenging. The field is limited by the absence of a diagnostic gold standard, except for maybe brain biopsy and a few that have genetic confirmation. The workup is very expensive. It incurs risk because you need brain biopsy, for example. Other patients require CSF studies. There's a lot of talk about doing advanced vessel wall imaging or black blood imaging, for example. In my experience, these have low specificity, but yet we're using them as kind of a gold standard, which has limitations. Brain biopsy, as you know, is commonly done in the right frontal lobe, and it's usually blind and not a targeted brain biopsy, which is why you get a high rate of false negative results. In my experience, if you target it to the active lesion, the results are it's much more positive. Because it is so challenging to diagnose, empiric treatment is common, and that's a mistake. You might think it's vasculitis and start treatment, only to later discover that the patient actually had an infection like varicella zoster or something else, which the treatment of which might be different. Another approach is to classify arteriopathies as benign or reversible versus progressive if untreated. And I've focused my career on this approach, which is where do we doctors need to diagnose promptly and start treatment versus leave the patient alone, not much is going to happen. There's been a lot of progress, not only in young adults, but also in childhood. They've come up with their own classification system. This is data from the WISP and the Cascade study. They've classified them as focal arteriopathies, which could be inflammatory or from dissection, Moya-Moya disease, and less common forms such as reversible vasoconstriction syndrome, which can occur in children, fibromuscular dysplasia, and others, which are seen in children. There again, they've taken the approach of, what's the clinical and angiographic pattern, and is it a reversible process as in FOCUS, a focal cerebral arteriopathy, or is it progressive, as in patients with Moya-Moya disease? How do I approach diagnosis and management? I think these are important issues. There's no clear right answer, but this is what I do and what I suggest. First, we examine the patient very carefully. Now, this is an amazing paper in Stroke 2019, I find, where you take a detailed history about the family history, neurological symptoms, and then on exam, you focus not just on the brain and musculoskeletal, but also on the hair, eyes, skin, and other organ systems. And you can find that, for example, let's take any of these, the alopecia, that might reveal an underlying HTRA1 arteriopathy, for example. So you have to think about the patient as a whole and do the thorough exam and identify systemic markers of underlying arteriopathy. For example, lax skin, ectopia lentis, high arch palate. These are markers of underlying connective tissue disorders, for example. So this is a worthy reference. I find this quite useful. In the young adult population, it is rare to find and uncover a new diagnosis, but in the pediatric population, I think this is really, really important. A friend of mine, a former fellow and resident, Dr. Abbas Karal and his colleagues from Cleveland Clinic, have published a recent paper in Neurology Genetics talking about the approach from their viewpoint when you suspect genetic arteriopathies. So this is an important table where if the CSF is inflammatory, there's one group, including CREX1, which is a common and commonly overlooked arteriopathy. And if it's non-inflammatory, so their approach is, is the CSF inflamed or not? And does the patient have additional aortic involvement, yes or no? And that combination can reveal a variety of genetic or inflammatory arteriopathies as listed here. They have also simulated the pediatric approach, where they go on to talk about the systemic manifestations of arteriopathies where the brain is also involved. For example, you might see cognitive changes with headache and mood disorders with a genetic predisposition that might reveal CADASIL even before the MRI, for example. So I think yet again, this is the same continuum from childhood to young adulthood, where the whole body is important to examine, and then CSF as well. While that is published, my own practice is to get clinical clues. I'm going to highlight a few that to me are pathognomonic. Headache just above the right eyebrow or the left eyebrow. And this is a famous paper by Dr. C. Miller Fisher, who was the father of stroke. He was at my hospital. He described the headache and pain of carotid artery dissection. And if the patient points here, I think that's a clue that you should look for dissection on CTA. I have described this syndrome of reversible cerebral vasoconstriction syndrome. I'll tell you a little more, but most patients, 90%, come in with recurrent thunderclap headaches, abrupt, very severe headaches, 3 or 4 of them. And that, I think, is a diagnosis that you can make on the telephone. However, many patients with CADASIL, cerebral autosomal dominant arteriopathy, with subcortical infarcts and leukoencephalopathy, long name, abbreviated as CADASIL. Most patients come in with headaches, which are often termed as migraine, even though they may not have full migrainous features. Patients with primary angiitis or vasculitis of the central nervous system, they most often have a story of, doc, I've been not thinking right and I have this dull headache that's been going on. So about 50% of them can report headache. I grew up thinking that you can't get vasculitis without getting headache, but it turns out 50% of them don't really think of this headache as significant, so they never tell their doctors. And then patients in moya-moya, symptomatic moya-moya, can develop chronic headaches. So headache is a very important clue towards arteriopathy. Next thing I look at is a stereotyped TIA. So imagine if the artery is narrow, every time there's a positional change or alteration of blood pressure, for example, you might have ischemia in the brain, and that tends to be identical repeatedly, suggesting a fixed arterial stenosis from things like moya-moya or a focal arteriopathy, such as zoster. I'm very careful about the clinical setting. A recent history of infection is important. It can reveal underlying zoster. The patient has chickenpox recently, for example. I've seen patients in adults where the child had chickenpox and somehow they got arteriopathy. Tuberculosis is, I think, common in India, where I'm from, and in Russia and other countries, so that's important. HIV, and I think I would add here COVID-19 infection, even though it may not cause an arteriopathy, it can cause inflammation around and therefore provoke headache and strokes. Illicit drug exposure, vasoconstrictive drugs, recent pregnancy, chemotherapy are risk factors for developing RCVS. On the systemic exam, be very sure to check all the arterial pulses. Frankly, you should be doing that in any patient with stroke, but especially in young people, including the temporal pulses over here, because if they're absent or if there's tenderness, the patient likely has giant cell arteritis. This last week, I saw a patient with an absent radial pulse, and we diagnosed Takayasu's. A skin exam might reveal things that you may not consider. Dago's disease, small atrophic papules on the skin, or zoster or neurofibromatosis, which could lead to moya-moya syndrome. Connective tissue disorders, things like ectopia lensis or lax joints or skin. You do the height and arm width to detect Marfan syndrome. On neurological exam, patients with infections or vasculitis could have multifocal deficits, including in the peripheral nerve, for example, in zoster. And then no patient of mine goes out without a dilated fundus exam to look for clues within the eye. for example, RVCL or genetic arteriopathies, often have secondary changes within the eye, in the retina. Abnormal CSF results, of course, and then pay a lot of attention to brain imaging. As neurologists, we rarely get pathology, brain biopsies, and our clues rest upon brain imaging, which is a surrogate for pathology nowadays. So look for things like this. The string of pearl appearance, this, if the patient has, is almost diagnostic of an underlying middle cerebral artery stenosis, and less commonly a severe ICA stenosis or recurrent artery-to-artery emboli from a dissection, for example. It's the same thing about spots all over the brain could reveal vasculitis. There's not too many conditions that cause small vessel strokes in both hemispheres or in the peduncles. That's typically vasculitis. In this condition I've described, RCVS and PRESS, these are disorders of cerebral autoregulation. You can get posterior predominant infarctions, usually in the watershed between the MCA-PCA or MCA-ACA. CADASIL has a pathognomonic MRI appearance where you get white matter change in the external capsule and anterior temporal lobe, and I think that has 100% specificity for CADASIL. And then Susac syndrome, which is the retinocochlear arteriopathy. On sagittal imaging in the corpus callosum, you get these blobs of change, snowball lesions. That also is pretty much diagnostic. Investigations should be directed at establishing the diagnosis, assessing stroke risk and progression. You should always do blood tests, always resort to the relatively non-invasive studies such as CT angiography and MR angiography. In my experience, both are valuable. I often get both in the same patient. Why? They're slightly different imaging techniques. CTA, you give contrast, it has fine resolution, you're looking at the lumen irregularities. On MRA, it's time of flight imaging, so you're looking at flow, and quite often I find MRA to be even more sensitive than CTA in certain arteriopathies. So frankly, I rely on both, not just one imaging technique. Transfemoral cerebral angiogram is considered the gold standard. I would caution you, I think if you're seeing abnormalities on CTA or MRA, I don't know what is the added value of doing a cerebral angiogram to reconfirm what is very obviously abnormal on non-invasive studies. So I think the role of angiography, in my opinion, is somewhat limited. If the CT and MRA are negative and you're still highly suspicious, you might do an angiogram to look for very distal fine vessel abnormalities. But if you do see them, I think you're probably more likely to make the diagnosis, but then the diagnosis will rest upon things like CSF abnormalities and brain biopsy anyway. So angiogram and moya might be important to reveal the fine arteries that form the tuft of smoke, for example, in the proximal MCA. It is very important to do a lumbar puncture, a body PET to look for systemic inflammation, and also look for the risk for stroke, so cerebrovascular reserve in patients with proximal arterial narrowing. I hope this is making sense. As I said, advanced MRI has been developed for cerebral arteriopathy. This is also called black blood imaging or post-contrast imaging with high resolution. I think black blood is apparently more sensitive for arteriopathy and also can reveal leptomeningeal change. So here are some examples. A lot is made in literature about the pattern of enhancement seen in the arterial wall. For example, eccentric involvement or concentric involvement can distinguish between, they say, atherosclerosis and vasculitis. I find that the data is limited by the absence of a gold standard for the final diagnosis. So if you see, let's say, this pattern, and you say, oh, this patient has athero, we don't really know if the patient doesn't have vasculitis or maybe even a focal dissection of that part of the artery because we're not doing pathology. So be careful about over-interpreting the advanced MRA findings. The Cleveland Clinic group, again from Dr. Karal, they've started doing routinely 7 Tesla vessel wall MRA, which can show you the very fine architecture of vessels. We've started that at Mass General Hospital as well. So I'm going to wrap up with a few selected conditions. Dissection affects about 2% of all ischemic strokes, but a quarter of patients who are young, and these are the incidence rates, 2.6 per 100,000 for the carotid and 1 per 100,000 for the vertebral. These are data largely from the Mayo Clinic series. Dissection peaks in the 5th decade of life, and that's because in that age group, the arterial compliance enables tears of the artery. When you're too old, let's say 65 and above, you have hardening of the artery, so the chances of spontaneous dissection go down. In the very young ages, intracranial dissections are somewhat more common. So as you probably know, this is from an article 25 years ago, the tear allows blood into the wall of the artery, which accumulates here. And you can see that on the axial T1 fat-saturated images as a mural hematoma. Stephanie Debet in Europe has been doing this amazing study, prospectively gathering data on patients with cervical artery dissection, with or without a stroke, and they find that hypertension is a risk factor with an odds ratio of 1.56 for both carotid and vertebral artery dissection. However, look at all the other risk factors: diabetes, smoking, cholesterol, obesity, high body mass index. Some of them are significant, but the odds ratios are all below, suggesting that they might be protective against dissection. Again, supporting the notion about hardening of the arteries due to atherosclerosis might prevent spontaneous dissection. The AHA, American Heart Association, has come out with a scientific statement and a guideline about management. The real guiding principle here is that if the patient is symptomatic, consider dual antiplatelet therapy within the first couple of days, otherwise aspirin alone is adequate. In the high-risk category of patients with low bleeding risk, you might consider anticoagulation, and high risk being patients with features of intraluminal thrombus or very significant arterial narrowing. At Mass General Hospital, we used to give heparin for a long time, but after trial data was published, we have curtailed it to only in the first 3 to 4 days, and after which we switched to antiplatelet therapy. There's not enough information about oral anticoagulation, but if there's high risk, I think it might be reasonable to switch from intravenous heparin to oral anticoagulation for the next few weeks until the artery re-endothelializes, and then you can convert to aspirin. The syndrome that I've been most interested in is the reversible cerebral vasoconstriction syndrome. I really think it's a group of conditions, and what we have seen is really the identical clinical imaging features of these patients. They uniformly have segmental constriction dilatation and recurrent, worst ever, very severe thunderclap type headaches, where the time from no pain to maximum pain is about a minute, and most patients say it was the worst, like a firecracker going off in my head. The average age is 42 years. Children can be affected. In the beginning, MRI is typically normal in 70%, and some patients can develop complications such as surface subarachnoid hemorrhage, which is not aneurysm, it's along the surface, or ischemic stroke in the back of the head, watershed territories. Some patients can have deep or mainly lobar hemorrhages. This is a condition where you don't have to do much. The patient will get better. The clinical deficits, if any, largely resolve. And I've been very firm that this is a benign condition relative to the, very severe headache and even the strokes. Patients walk out of the hospital with a modified Rankin scale score of 3 or less in 95% frequency. So I think I would argue that this is benign. Long term, however, patients can have chronic headache and depression, but it's still important to emphasize benign so that interventionalists and surgeons don't go around intervening in a condition with a natural history that is good. You can recognize these are the stroke lesion patterns that I was talking about, watershed territory. 30% can also have these press or idiomatous lesions on flare. And then these are the types of surface bleeds and lobar or deep hemorrhages. In some patients, this is the same patient, by the way, can have a combination of stroke, hemorrhage, convexity, surface bleed. And I think there is no other condition that causes all three simultaneously. I've also developed a score called the RCBS-2 score for recurrent or single thunderclap headache. That's the R. C is for carotid artery intracranial narrowing, which should be absent. If it's present, think about moya moya. And then vasoconstrictive trigger, Imitrex or antidepressants or marijuana even could be considered a vasoconstrictive trigger. And then S2 stands for sex and the convexity type subarachnoid hemorrhage. This score is mainly driven by the recurrent thunderclap headache, which gives you half the total score of 10. Primary angiitis is a different inflammatory condition. You suspect it when patients have accumulating strokes with either angiographic distal arterial changes, multifocal, or a biopsy proves it. And of course, you're ruling out mimics. It's not well understood. As I said, 50% have headaches, and multifocal deficits are common. In the 50s, when it was described, it was considered a fatal condition. Data from the Mayo Clinic by Salvarani and others, they have shown that it actually is also possibly self-limited or responsive to treatment, with a lot of patients, especially those with gadolinium-enhancing changes, seem to respond to immune suppression. There are many pathological subtypes, as I've mentioned here, including a solitary mass lesion presentation, which we described, which appears like glioblastoma, but on pathology reveals PACNS. These are the infarct patterns. They're sort of different from RCVS. Both conditions have stroke, but look at the pattern of strokes. These are small strokes deep in the brain, not the superficial watershed type. A lot of white matter change is common. This is the mass lesion presentation. And rarely, 9% of patients in my cohort develop these larger MCA or PCA type strokes, and very rarely brain hemorrhage as a complication. So you can give any form of immune suppression. I don't think there are clinical trials in adults. In the pediatric population, cyclophosphamide seems to be effective. That was Susa Bressler in the New England Journal of Medicine. There was a trial. So as I said, 80% can respond. The subtype does not predict response. There's a high rate of relapse. And of course, those with pre-existing cognitive change or multiple infarcts have poorer prognosis. We published a review paper, and this was an important table, all the various mimics of angiitis, those with primary brain lesions, those with angiographic changes, and then systemic conditions with secondary involvement. Amyloid is becoming an important entity. A-beta deposition can provoke inflammation, and this entity is called A-beta-related angiitis. And this pictorial shows you the differences between CAA, or cerebral amyloid angiopathy, where there's abnormal deposition of amyloid in the vessel wall. This is what I'm referring to, inflammatory CAA, where you get inflammation surrounding the vessel, or a true vasculitis, where there's inflammation within the vessel wall. Here, the differences between PACNS is there's amyloid deposition, whereas in PACNS, it's inflammation, but without the amyloid deposition. So these two are almost identical, ABRA and PACNS. And finally, intravascular lymphoma. This is why you should do biopsies in patients where you suspect vasculitis. You don't want to miss this entity. You can, again, the presentations are similar, but the pathology, if it reveals lymphoma, puts you down a different chemotherapy pathway of treatment. Finally, very recently, we've heard of cancer-associated stroke, but I've come across this entity, which we published in a clinical pathological conference, where the patient had everything going for vasculitis, primary angiitis, including concentric wall enhancement, as you can see here, multifocal strokes, headaches, recurrent strokes, but then had this spiculated mass in the lung and kidney. It turns out that this patient's pathology showed paraneoplastic vasculitis, where there was burnt out inflammation, suggestive of a kind of a paraneoplastic process. So this is often ignored. Fibromuscular dysplasia, you get the typical imaging appearance that clinches the diagnosis of accordion or beaded appearance, typically of the carotid and vertebral arteries. I think this is generally a benign condition in the absence of dissection. We followed patients who received aspirin, and very few developed a sort of a focal syndrome that may or may not be ischemic in nature, TIA, but none developed a stroke. And then don't forget Fabry's disease, which is accumulation of the alpha-galactosidase A, which can cause big arteries, ruptured arteries, mainly in the vertebral artery. And it's important to do the gene test because enzyme replacement is now available. And there's a fabryregistry.com where I think you can upload patient data and get more information. Again, as I said, skin exam is important. You can get these interesting skin lesions, angiokeratomas, along with very rarely intracranial affliction of FMD. So I know I'm out of time. I will stop, and I don't have time to cover the many other very important arteriopathies, but maybe next time I look forward to coming back to the Summer Summit and giving you further education. So I'll stop the slide deck and be open to any questions. Thank you.
The next lecture is by Professor Ramesh Sahativan from New Zealand, a neurologist and expert in stroke prevention and the stroke riskometer, who will discuss improving stroke risk awareness in the general population.
I'd like to start by thanking the organizers of the Ukraine Summer Stroke School 2026 for inviting me to participate. My special thanks to Professor Yuri Flomin and Dr. Marina Gulayeva. This is the 4th year that I'm contributing to this incredible undertaking, and I'm truly honored to be a part of this. I look forward to the day that I can deliver a presentation at the Summer Stroke School of Ukraine in person, and I would love to visit your beautiful country. I said during last year's presentation that I would be doubly honored if anyone from Ukraine who was attending the European Stroke Conference would come up and say hello to me, and I am going to repeat that this year. Obviously, the Stroke Conference is going to be held before the Summer Stroke School in Ukraine, but yeah, for whatever it's worth, it'd be lovely to meet some of you in person. Thank you again. My name is Ramesh Sahadavan, and Yuri and his team have tasked me with the topic of looking at the effectiveness of the stroke riskometer in improving stroke risk in the general population. As an outline, I'm going to be speaking about firstly what the burden of stroke is, just to give us a bit of a setting in terms of what's going on. Going then into what the stroke riskometer is, how it's applied, how it's evolved, and how we can use it. So the burden of stroke is an unfortunate global undertaking, or has global implications, I should say. It is still a significant cause of disability and death. All of us in the world of stroke know that about 80% of stroke are ischemic. There's, of course, a degree of variation depending on which part of the world you're in. But unfortunately, what does not vary from place to place is that 1 in 4 people are at risk of developing a stroke in their lifetime. In the initial stages, we always regarded stroke as the second leading cause of death globally. In 2020, that changed. And stroke has now fallen to 3rd place in terms of a cause of death, following ischemic heart disease, and not surprisingly, of course, COVID. Another fact that has not really changed much over the years is that 1 in 3 people with stroke still die within the first 12 months of the event. Stroke is the leading cause of disability in the world, with 116 million disability life years. If we break it down further, from the Global Burden of Disease study, we know that ischemic stroke constitutes about 7.63 million cases in 2019, causing 3.2 million deaths. This resulted in 63.48 million DALYs, an increase of 57%. Intracerebral hemorrhages constituted 3.41 million cases in 2019, and this led to 2.8 million deaths, with a total of 68.57 million DALYs, an increase of 25% between 1990 and 2019. Subarachnoid hemorrhages accounted for 1.18 million cases in 2019, and this led to 370,000 deaths, with a total of 11.18 million DALYs. And there was a decrease of about 14% between 1990 and 2019. Obviously, the much lower number of subarachnoid hemorrhage is in keeping with the mechanism, which is, of course, much less common than ischemic stroke and intracerebral hemorrhage. And just to remind us that DALYs are disability-adjusted life years, as I'd said earlier, and this is the sum of the years of life lost due to premature mortality and years lived with disability. A DALY constitutes 1 lost year of full health. From the Global Burden of Disease studies that have now become quite part of our approach to most diseases, we know that in 2013, when the first iteration of this was published, that for the first time we were able to tell our patients that 90% of stroke were due to 10 modifiable risk factors. They were clumped as behavioral factors, which included smoking, poor diet, and low physical activity; metabolic factors, which included high systolic blood pressure, high BMI, high fasting plasma glucose, high total cholesterol, and a low glomerular filtration rate; and environmental factors, air pollution and lead exposure, which for the first time were implicated in the risk of stroke. In 2024, the next iteration of the risk factors of stroke and the burden were published under the Global Burden of Disease, looking at data from 1990 to 2021. As I said earlier, stroke was then identified as the 3rd most common cause of death in the world, after ischemic heart disease and COVID-19. Based on the assessments done through the Global Burden of Disease, there were 93.8 million prevalent and 11.9 million incident strokes. And there was a disparity in how much, or rather how affected people were according to where they lived. And of course, with that, the effect of their socioeconomic backgrounds as well. The interesting thing was that in addition to some of the risk factors that I've already spoken about, other issues such as high ambient temperature, thought to represent the events of global warming and the use of high sugar-sweetened beverages in diet, as well as a diet low in omega-6 polyunsaturated fatty acids, were uncovered as being further significant risks of stroke. When this was looked at further, targeting a young population, what was unfortunately discovered was that stroke in young adults, those between the ages of 18 and 49, increased by 36%. Excuse me. Looking at the risk factor profile, high blood pressure remained a primary risk. And looking at whether there was a variability by region, it was discovered that there were a higher proportion of people smoking, those with high LDL cholesterol, a high body mass index, and not surprisingly, in high socioeconomic regions. Whereas in lower socioeconomic regions, factors such as household air pollution from solid fuels and diet low in vegetables was more likely to be related to an increased risk of stroke. Again, looking at the stroke risk factors from a DALI point of view, it was demonstrated that high blood pressure, air pollution, a high body mass index, high LDL cholesterol, and high fasting blood glucose were again issues that were associated with a higher risk of stroke. Why is all of this important? It's important because these constitute a part of what the stroke riskometer is. So if we're looking at the stroke riskometer and what it is a mobile app that was initially introduced, I think, in 2012, or the ideas were that were behind it were sort of like born in 2012. And in the initial stages, we would advise our patients that there was a product that they could use to determine their risk of stroke that was available as an application for both iOS and Android phones. This mobile application was developed by Professor Valerie Fagan and his team at the National Institute for Stroke and Applied Neurosciences at the Auckland University of Technology. There were, of course, global experts who were involved in contributing to it as well. And it was the first of its kind. And what it allowed was that it allowed for individuals to do a self-assessment of risk for cerebrovascular and cardiovascular events, as well as dementia. And this was based on their knowledge of their own risk factor profile. Based on the information they put in, they could then calculate a 5-year and 10-year absolute and relative risk, meaning that they were able to determine what their risk of developing these conditions was based on peers who did not have risk factors. Included in this was a bit of a self-management portion, and there were approximately 26 language versions that were available. As I'd said earlier, it was available for both iOS and Android platforms. Was this a good idea? And I think it was. And one of the bases for that is to say how much the penetration of mobile phone ownership is globally. It's estimated that 82% of individuals aged 10 and older own a mobile phone, and that roughly 70% of them use it to access the internet. Unsurprisingly, high-income nations have in excess of 95% penetration, but even in low-income regions, about 50% of the population own a mobile phone. There are estimated 5.78 billion unique mobile users globally, with smartphone adoption nearing about 90% in developed regions. How was the stroke riskometer developed? And as I said, there were a number of experts in the field of stroke who contributed. And the initial assessment was based on a unique grouping of about 9,000 individuals across three countries, New Zealand, Russia, and the Netherlands, looking at 752 stroke outcomes. And it was a risk prediction tool, as I stated, that was compared with two established stroke risk factor prediction algorithms, which were the Framingham stroke score and something called Q-stroke. The stroke riskometer performed well against the Framingham tool and actually outperformed the Q-stroke tool. In terms of performance, the stroke riskometer was comparable for stroke prediction with both the Framingham and Q-stroke. However, it was determined that all three algorithms performed equally poorly in predicting stroke events. The idea was that the stroke riskometer, being a mobile device and that collected data from users, would have the potential to grow, develop, and improve. When the stroke riskometer was first released, Professor Valerie Fagan as the creator, or as one of the leading minds behind the creation of it, published an editorial in the International Journal of Stroke alongside Professor Bunoving, where the stroke riskometer was described as a mass tool looking at cardiovascular, cerebrovascular disease in terms of a determinant of risk, and hopefully by that, prevention. It was touted as being novel based on two distinct features. One was that it allowed utilization of mobile technology, and that people who used it were able to, as I said, calculate the 5 and 10-year absolute and relative risk of stroke. More importantly, it was about empowering patients, empowering individuals, and allowing for self-management strategies. How was the stroke riskometer then applied? In the initial stages, there were smaller studies. This is a study that was done out of New Zealand. As I said, this is where the stroke riskometer originated. The initial results of this were a brief report published in Stroke in 2019. The authors conducted a parallel open-label two-arm prospective proof of concept pilot randomized control trial. Those participants who were involved were randomized to usual care or use of the app to guide the management of their risk factors, and assessments were done at baseline 3 months and 6 months. Participants were, of course, aged above 19 years. They had 2 modifiable stroke risk factors and no history of stroke prior. And of course, they had to own a smartphone. There was a small group of participants, 24 in the control arm and 26 who used the app. And what, excuse me, the results showed was that there was no actual difference between the groups statistically, but the authors concluded that it was enough evidence to then encourage people to look at using the app and for more in-depth trials. In many parts of the world, we rose to the challenge. This was something that was done by my colleagues when I was still in Malaysia, where the stroke riskometer was looked at for its effectiveness in improving stroke risk awareness. I I'm also quite proud to say that I contributed to the stroke riskometer by helping to create a Malay language version. The translations were done professionally, and I was then invited to edit the outcomes. The stroke riskometer has also been used in other places. This was a protocol that was published in 2015, looking at a population in China, where again, the impetus was that stroke numbers were rising, that stroke risk factors were largely unidentified, and that by hopefully identifying the stroke risk factors in the population, there was going to be an increase in patient awareness and hopefully then a decrease in the number of stroke. This is a study that was done in Ghana. This was an interesting study in my view, as it utilized the stroke riskometer as a means of determining risk factors and immediately calculating a patient's 5-year risk score. But instead of asking patients to use their own devices and evaluate their own risk on a certain day, and this was in conjunction with World Stroke Day, the researchers recruited people who were at a certain market in Ghana and then immediately assessed their stroke risk and their stroke risk factor profile. So I think this is an interesting way in which the stroke riskometer was then used to determine who might be at risk and what could be done to help them. As part of the idea, of course, of using a tool like this, the question, of course, is this something that can be used across regions? Is it something that would not be affected by patients' geographical location or culture? This is a study looking at the use, or rather using, a fairly advanced statistical model called the generalizability theory, or G theory. And what the researchers found is that by analyzing data from about 1,300 participants in 13 countries, that the use of the riskometer didn't quite matter in terms of where in the world people were, and that there was a definite ability to generalize the use across populations and countries. So how has it evolved? And it's evolved quite dramatically. Some might argue that, evolution isn't always a good thing, especially if you consider that the last figure looks disturbingly like a certain world leader whose name I won't mention. But evolution is something that I think is required. And so the stroke riskometer has also now evolved. In this editorial, published in 2022, the group behind the original stroke riskometer argued that there was still alarming lack of public knowledge regarding stroke warning signs and risk factors. And so by this, the risk of stroke remained high. What was this due to? The other issues that the authors felt was that there was an absence of an evidence-based approach to determining whether patients would be able to identify their risk factors and act on it in a sort of a patient-centered approach. The authors spoke of particularly an absence or a paucity of digital tools. They also spoke about something that I think all of us are familiar with, and that is the inadequate time that many of us have in a clinic setting to address these issues and properly evaluate them. So from this, the stroke riskometer incorporated something called Prevent Stroke MD. And this was now a tool that was designed for healthcare professionals, and it was web-based and could be connected or included into existing electronic patient record management systems. The idea was that it would help for healthcare professionals to determine their patients' risk of events such as stroke, but maintaining that the evaluation and subsequently the recommendations would still be very much tailored to the individual. The Prevent Stroke MD platform contained 5 main domains. This was regarding the setup, the administrative, analytical, and data security issues, risk assessment, preventative recommendations, and smart goal setting. So from this, I think we can recognize that there was a very systematic approach in terms of how the stroke riskometer was then evolved into the Prevent Stroke MD platform. And as I said, that the preventive recommendations were still going to be very much patient-centered. And in terms of smart goal setting, as I said, specific, measurable, achievable, realistic, and timely. The Prevent Stroke MD web app for prevention was based on a 2-phase survey that was done internationally based on input from healthcare professionals across the world. In the first phase, the prototype was tested on healthcare professionals, as I said, from different backgrounds, age, sex, work experience, and it was rather assessed using hypothetical data. In phase 2, the almost final version of Prevent Stroke MD web app was tested on 58 healthcare professionals using both hypothetical and real patient data. In the final analysis, the prototype and the final version showed that there was good usability and that this was not affected by whether you had that you were older, regardless of whether you're male or female, what level of work experience you had, or what the speciality was of the healthcare professional. This has now been used incorporated into a study that was that is running, if I'm not mistaken. And again, using a stroke riskometer application as part of the evaluation and assessment. We all know of the utility of using a polypill approach in terms of managing patient risk factors. This is a randomized controlled trial looking at the effective management of hypertension and hypercholesterolemia using a polypill consisting valsartan 80 milligrams, amlodipine 5 milligrams, rosuvastatin 10 milligrams, with and without the use of the stroke riskometer app, looking at systolic blood pressure and other cardiovascular risk factors at 9 months. The study design is as stated, and it will be conducted in Brazil. And centers would be randomized to use of either the stroke riskometer app or standard care for lifestyle modification. The dual primary outcomes will be a change in the systolic blood pressure and the Life's Simple S or LS7 score at 9 months. The idea is obviously polypill versus placebo, stroke riskometer app versus standard care of lifestyle modifications. And this would then give us a 2x2 table with 4 outcomes possible. The analysis will be, as I said, concerning changes in systolic blood pressure, cholesterol levels, cognitive function, and behavioral risk factors over time. I look forward to the publication of this study, and I think I agree with the conclusion of the authors that it will provide us critical information looking at development of primary stroke care and CVD prevention strategies in those who are low to borderline risk. And I think in a resource setting that is not entirely that of a developed country. So how can we use it? This at the bottom is the address for the website. This is what the Prevent Stroke MD sorry, this is the landing page for writing in to AUT to request access to the Prevent Stroke MD application. There is obviously a shift of focus if you compare the stroke riskometer to the Prevent Stroke MD tool. And it's gone from being patient administered to HCP administered. However, we are still looking at the same risk parameters and looking at the same determinant of 5 and 10-year relative risk of stroke and related conditions such as myocardial infarction and dementia. This is an easy web-based application, and it can be used in consulting rooms. And I say that with the knowledge of having used it myself, as I was part of the original group of healthcare professionals involved in the validation that I mentioned earlier. The focus remains patient-centered. So in conclusion, the stroke riskometer as a mobile device application unfortunately no longer exists. Prior to discontinuation, it was demonstrated to be effective and reliable in estimating relative risk of primary outcomes such as stroke and cardiovascular disease. More importantly, there was good acceptance amongst users. Why it was discontinued is a little unclear to me, but perhaps it had to do with the sort of, I guess, no doubt having a tool available does not always, unfortunately, equate to the tool being used. Now, it has evolved to the Prevent Stroke MD platform, developed by the same team of experts. And I think that it will be something that will change how we're able to manage the risk of our stroke patients in the future. Ladies and gentlemen, thank you very much for your time and attention.
That brings us to the end of plenary session 2. We now move to special session 1, which will focus on case-based clinical decision-making in complex stroke scenarios. This session will address evidence-based decision-making in complex acute stroke cases, common pitfalls that may lead to futile or harmful interventions, and the integration of imaging, comorbidity, and patient-centered outcomes into treatment decisions. The moderators of this session are Dr. Mark Dannenbaum from the United States, Associate Professor of Neurosurgery at UT Health Houston, and a neurosurgeon with expertise in vascular and endovascular surgery. Professor Yuri Flomin from Ukraine, head of the Stroke Center at Oberik Clinic in Kyiv. Dr. Katerina Potapova from Ukraine, neurologist and faculty member of the Department of Neurology at Bogomolets National Medical University. Dr. Stanislav Konotopchik from Ukraine, neurosurgeon at the Practical Center for Endovascular Neuroradiology of the National Academy of Medical Sciences of Ukraine. And Dr. Andriy Smolanka from Ukraine, neurosurgeon at the Uzhhorod Regional Center of Neurosurgery and Neurology. Thank you for joining us today. We'll look forward to seeing you tomorrow when the program will focus on intracerebral hemorrhage, neurosurgical approaches in acute stroke, and new frontiers in cerebrovascular diseases.